This assessment process, being the first of its kind to standardize across the entire province, is being looked at from across the country. So there's other examples, for example, in medicine, that they have a national assessment process that happens all on the same day, if you can believe it. They adjust for time zones and things like that, but it's a national assessment process for all physicians, and that happens a couple times a year. And so the Paramedic Association of Canada and other organizations across the province are very interested in having a national assessment process, but it's just an enormous undertaking, as you can imagine, given just what we're working here in Ontario. So the reason I bring that up is because Ontario is, I'm sure, going to become the model for other provinces going forward. Nobody is doing what you guys are doing in the next little while here across the country. So, and in terms of defensibility, as Richard said, reliability, validity, all that stuff, this is definitely cutting edge in the paramedic industry. So that's, really great news, and I recognize that there's a lot of experience in the room, and certainly more than me in a lot of ways. So my contribution today is really just to bring to you and give you as much information about assessment as possible. We're going to definitely work on the rater piece and rater training piece. My assumption is that you guys are going to be the raters in this assessment process. But if you're not, if it turns out that there are other people in your organizations that will eventually become raters, then you can probably take what we talk about here and bring it back to your home organizations and do some of this as well. So as far as introductions for myself, my name is Walter Tavares. My full-time job is at Centennial College. I'm the paramedic program coordinator there. And my research is mainly in assessment of competence and a number of different areas of that. One of the things that I really focus in on is on rater training, rater cognition, things like that. Not rater training, but more rater cognition and how people make decisions about competence. So I'm going to take a lot of that work and bring it into today and work with you to try to get us somewhere where we can really make sure that the process works. There's basically two areas that this can fall down. And I'm going to give you some background here in a bit, but there's basically two areas that this entire process can fall down. The first is the content, and the second is the raters. If the raters aren't right, the process can fall down. So those are our two biggest threats to this entire machine. And so no pressure for the group that's working on that. And again, I'll explain that. And what part of my strategy today is to give you some background information so that you really understand your role in this whole process and you understand the entire process as it's built. Let me just tell you what we're going to cover today. So the first thing is we're going to talk about, thank you, the psychometric principles associated with performance-based assessment. I want to give you that because I want to make sure you understand your role in this entire process. And there's going to be two things I'm going to talk about later, about consistency and differentiation. And I want to make sure that you understand where those two things, which are your responsibility as raters, come into the big picture. Okay, so I'm going to give you that. So a little while back, the base hospital asked me to put together, I guess, a review of the literature, which I then gave, which had some recommendations on there. So you probably didn't see that, so maybe you did, I don't know. But we're going to go through very quickly those recommendations to talk about why those recommendations exist. So again, you understand this whole big process, recognizing that you're more than just raters here. We're going to talk specifically about the Ottawa-based hospital for some reason, but the Ontario-based hospital system, the way the assessment process is going to work. And again, I want to make sure you really understand that process, including the scoring strategy, which is probably a little bit different than what perhaps you might be used to. I'm making an assumption there, but it's different than what we used to do at the college, and I'm sure and being around the province quite a bit about this, I recognize that there are some differences. So I'm going to explain that process very clearly, so again, you understand where your grades, where your scores will go, and how they're going to be used, which is probably a little bit different, like I said, than what you're used to. We're going to discuss the global rating scale in detail, talk about how it was put together, the evidence around it, and then how you interact with it. You'll notice that there are no checkboxes there, and we're going to talk specifically about that, about the pros and cons about this idea of objectivity versus subjectivity. We totally depend on your judgment. I'm not afraid of your judgment. I'm not afraid of the subjectivity. I want it. I think it's powerful, especially when you have a big group like this. So we're going to talk specifically about that because there's a lot of concerns traditionally around that issue of checklists versus global rating scales and objectivity versus subjectivity. So we're going to go after that specifically. We're going to discuss your role as the rater in this entire process, and then we're going to drill down and get down to identifying strategies at improving rater performance. And that'll be sort of definitely the big takeaway for today. Okay, so the first task I'm going to get you to do is watch this video and just score it. Just rate it on your own. Don't talk about it. Don't talk to each other about it. Don't cheat. Don't look at each other's scores. They're going to use the global rating scale. I'm intentionally not describing too much about it at the moment. I'm just going to let you do what you do, as you would normally do. And you're just going to watch this performance and score it. This is the student you're going to be evaluating. This is in the back of an ambulance. And the case is basically, the story is that there's a transfer company doing a transfer from one hospital to home or one hospital to another hospital or something like that. And the patient gets sick. They shouldn't have transferred this patient, basically. And this is a transfer company that's not equipped to handle patients like this. And so the patient gets sick, and they call for an ambulance or paramedics to come and save the day. This guy shows up. You can imagine a response unit, so he's by himself, and he's got these two. You'll see people in here in a minute. He's got these two people in there that are there to help him as much as he wants to use them. Okay? One of them, I'll tell you, is a little bit more competent than the other, and another one wants nothing to do with anything, and one of the other attendants from the transfer company is willing to help, has some skills, but again, not certified as paramedics or anything like that. The patient eventually, so what you see on here is the blood pressure, respiratory rate. This is probably a familiar view for you, and then the ECG that the patient's currently in. And the patient eventually deteriorates and goes into cardiac arrest.
Oh my God, he's here.
Oh my gosh, finally someone who's competent.
I don't know what to do. I did a blood sugar on this guy and I don't know what to do. He's not responding to me. Like, I was trying to talk to him and he's not responding back. He's not talking to me at all. You have to help us.
Honestly, Victor, you have no idea what you're doing.
You're a paramedic, right?
What are your names?
I'm Victor.
Okay, and your name?
Yo, you have to do something. I don't know what to do next.
What's our patient's name here?
Just let him do
Jim.
his
It's
thing.
Jim.
Alright,
You have no idea
so
what you're doing. Just let him do his thing, okay?
Me?
That's
Diaphoretic.
you.
I'm a student.
You're student.
Jim, can you open your eyes for me?
I'm only in first year.
Alright, Jim, can you open your eyes for me? Jim,
Oh my gosh, Victor.
do you know where you are right now? Can you squeeze my
document
fingers?
this?
I'm not going to document it.
Yeah, you have to.
Do you want to lose your job? I'm not going to get a job if you
What
don't.
liter flow do you have him at?
10 liters.
If you don't document it,
Oh, they're calling us.
Do you know how to use a cardiac monitor?
he's not.
Yeah, I know how to
What do
use
you
it.
want me
Can
to
you
tell this
put
guy?
leads on them as well?
Sure.
Victor, what do you want me to tell this guy? She knows we're not moving.
I don't know, just do your job.
Which is what do you want me to tell
Did you
this
guys get
guy?
a set of vitals?
I got a set of vitals.
Okay, come on, he's on my tail. What do you want me to say?
Would you be able to write down the last set of vitals that you guys got?
I didn't do
Last
vitals, Victor.
Did you?
I
did
just
say.
gotta tell him. What do you want me to tell
Can we
him?
do another one? It's been...
Hi there, sir. My name is Dan. I'm a paramedic. Can you tell me your name?
Victor, what do you want me to tell him? This is
Sir,
your
can you tell me your
issue.
name?
Just tell him that something's wrong with the car or something. Or the
what?
truck.
Alright.
Don't tell him this is what happened.
I'm not gonna tell him.
Just make up something. Tell him like we're low on fluid or windshield washer fluid or something, and we went out to go refill it.
Okay, fine, good. Dispatch is vehicle 1234, currently pulled over on the
Low
side
radio.
of 400. We
VTAC,
are low on watch
VTAC
fluid.
with
We're
a
gonna top
pulse.
up and we're
Okay.
gonna be mobile shortly. Okay, that's gonna buy us 2 minutes. Can you fix him up in 2 minutes, Mr. Medic?
We'll do our best, okay?
Because I
Calm
don't
down,
dispatch.
calm down.
Because you to calm down, you should be more nervous
I'd like to
than
request
me.
more.
I'm calm. I'm a little nervous.
Just working
I'm trying to stay
responsible.
calm.
Oh my gosh, this is your
It
fault.
can make it worse if we're all like worked up, you know? I don't know why. I don't know why you're always trying to complain and put it all on one. Put it on me.
Oh, I don't know.
Someone else when we're on this team, you know?
I don't know what to say to you, honestly.
Take deep breaths for me, okay, Jim?
I don't know.
Can you like stand up and do something at least instead of sitting
What do you
there?
want me to do? I can't. I'm not trained to do any of this.
We should have took some training and did some and took
I
some
drive.
initiative.
My job is to drive, and that's it. I drive. You do patient care, and that's
But having
it.
goals in life instead of driving? We've been doing the same thing for 10 years?
I like it. I'm happy. I'm satisfied right now. I have a great husband. I have great kids I have a great
You have
house.
fat kids. Your kids are fat.
Why? Like, no, like, why are you making fun of my kids? That's not even appropriate.
You should be able to, keep them, make them eat better.
So I hear some wheezing in the mid lobes there.
At least
I need you two to calm down. Can you tell me what's the history on this patient here?
Give me the sheet. Give me the med sheet that we had, the transfer sheet.
I gave it to you, remember?
Oh, I left it at the nursing
Oh
home.
my gosh, you can't even do that, right? It's ridiculous.
Okay, I remember. I have a photographic memory, so I know what he has.
Okay, what does he have?
He has had 2 heart attacks.
When?
He's had a stroke. I don't know when. He's had a stroke, 2 heart attacks, high blood pressure, high cholesterol, diabetes,
Okay.
He has
Some
such
sort of-
extensive
some sort of
medical
dementia.
history. Why would you take
some
it?
sort of dementia.
Okay.
Why
He's
did you take
70.
him?
He's like 74.
So?
All right.
So they have some of those problems from that.
Oh my
Jim,
God,
do you know where you are right now?
Well, she's healthy. Good for her.
Jim.
Why you shouldn't have taken him?
What seems to be the problem, Jim?
Get the transportation.
Can you tell me what's bothering you right now?
You made him walk for a stretcher.
You made him walk.
We
You
both
didn't
made
put
him
him
walk.
ahead. No, you did.
What was the last sugar you got on them?
8.8. If you didn't feel good, you should have told me that you shouldn't have been walking the
8.8,
stretcher.
You know what? You're higher up than
10
me.
years.
I know, but you're the medic. You're the one who's certified a patient. I'm not. Right? So there's no way I can say no.
So
and
what
say
exactly
yes.
happened? Victor, what exactly happened?
Okay, so we were on our way to a nursing home,
All right.
and then he was taking a nap, right? And then I was reading, and then I
Was
tried to
he
talk
taking a
to,
nap
and then
or you taking a
I tried to
nap?
talk to. Shh! I tried to talk to
Just
him.
1 second. Okay. Go on.
Okay, I was taking a nap too, and then I tried to wake him up, and he wasn't responding. He wasn't talking to me, and it looked like he was having some trouble breathing or something. So I don't know what to do. So I took a blood sugar.
Okay. So the sugar was 8.8.
Yeah, it was 8.8, which is good, right? 8.8. I don't know.
Yeah, okay.
I don't know what else to do. Can you help me? You know, I'm not gonna get a job as a medic.
You know, you
Okay.
don't deserve to get a job as a medic. Honestly, if this is what
I'm
you
only
do
in
to
the
a
first
patient,
You need to calm down. Just 1 second,
I'm
all
only
right?
first year, okay? I haven't learned everything there is to learn.
that's because you're not paying attention.
I am
Can you get the
attention.
SpO2 on him as well, please?
Okay.
Okay. Never mind. Get the pads on him.
The pads?
Yeah.
Okay, I'll get the pads.
Where are the pads? We have? Okay. So it's a witness arrest.
Oh wow, what do you want me to tell dispatch?
I don't know, just make something up
This
there.
isn't good.
You send me his experience on the video.
Okay, I'm gonna tell him that we're actually moving, just not
Pads are
driving.
on.
9 and 30.
Dispatch,
Okay, so it's a witness arrest.
where we currently are moving.
Alright, we're going to defib the patient. I'm clear, you're clear. Everyone get the BVM ready,
I don't know
okay?
what else to say.
Don't touch the patient.
Okay, so
VSA at 14:18. Alright,
this is not
away from the
good.
patient, feet off the stretcher there. Everyone away from the
This is not
patient. I'm clear, you're clear, everyone's clear.
Picture, this is not good. He's doing CPR. I'm assuming the patient's dead.
Good.
Obviously he's
No.
dead and he's doing CPR.
How was I
Why would he
supposed
be
to
doing
know?
CPR if he's
I
not
don't
dead?
know. I'm not medically trained like you.
Okay, our BVM is ready.
4 and 5 and 6 and 7 and 8 and 9 and 10 and 12 and 13
Oh my
14
gosh,
15 and 16
Jim. He was
18
joking with
19
us
20
earlier, and look
22
what.
23
look
24
where he is
25
now.
26
Oh
27
my
28 29 and 30. Give him 2 breaths. Gloria, can you come over here and do compressions for me, please?
No, I don't do any patient care. No, I'm not certified. I'm not trained to do
Okay,
that.
so that's 10, 11, and 12, and 13, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, and 30. Can you also say the base? Can I give 2 breaths, please?
Okay.
Right. We should have a good face mask seal, tile volume. How's my compliance? Alright, compressions?
Okay.
You're too slow. Here. Okay, here,
Faster?
here. Can you hold this? No. Okay, hang on. 1 and 2 and 3, 5 and 6, and 9 and 10, 11 and 12, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 25, 26, 28, 29, and 30. What's the ETA on my backup?
Are you asking
Any
me?
idea?
Why are you asking us?
I don't know. Did you Johnny drink this
You want me
fast?
to do something or what?
Yeah,
This
can
one
you do
is no
compressions
idea.
for me? I'll walk you through how to do proper compressions, okay?
I'm a paramedic student. I'm not a good compression.
Really
Time
not
there.
very good one if you can't do
All right.
compression.
All right. Go 100 per minute. Use the palm of your hand. A third of the chest. For chest recoil, okay?
4, 5, 6, 7, 8, 9, 10,
11, 12, 13,
24,
14, 15,
5,
16,
6,
17,
28,
18,
29,
20.
Oh my
30.
gosh.
That was 30.
Okay.
What?
Oh, I'm
Breath.
gonna lose my job.
3, 4, 5, 6, 7, 8, 9,
10,
12, 13,
14, 15, 16, 17, 21, 22,
Okay, he's looking for an update. What do you want me to say?
28, 29, and 30.
Mr. Medic,
What do you want her to say?
what do you want me to tell this
Just
guy?
let him know that the patient's VSA,
What's VSA mean?
vital signs
Why is someone's
absent,
ass means he's dead? Haven't you paying
Okay.
attention?
Okay, so try to tell him that you're here, I guess?
4 and 5 and 6 and 7 and 8 and 9 and
Dispatch
10.
vehicle 1, 2, 3, 4.
12,
We currently
14,
do
15,
have
16,
first
17,
response on
18,
scene who
20,
states that our
21,
patient
22,
is
23, 24,
VSA.
25,
We will
26,
provide
27,
an
28,
update.
29, and 30. Breath and breath. All right, back on compressions. Why is there, did the mark?
So what level are we assessing this candidate at? Excellent. Very important. That establishes your frame of reference to some extent. Yep. How much does the context matter? Which pieces of the assessment to extract and to score and to consider? So I'm just going to capture those couple of points there. So there was something about frame of reference and there was something about context. So the other piece of paper I sent around is this recommendations, summary of recommendations. I'm saving you, I think, 19 pages of reading and putting it just in a page and a bit here. So I'm going to go through these because this is what I think not was totally responsible for the assessment process that you're going to be engaged in, but helped inform it at least. Okay, so I want to give you the same information. So the first one there talks about to make claims regarding clinical competence, assess candidates at all levels of this Miller's pyramid, this thing called Miller's pyramid, and when it's not possible or feasible to assess at the shows how, build evidence to support, or I should say at the does, build evidence to support claims of performance at the level that's predictive of convergent with performance at the does level. What that means is, so this is Miller's pyramid, and so we've recognized that clinical competence is sufficiently complex as to require some level of structure. And with that comes this idea that we will move towards judgment in a bit. But basically, they provide this structure. And they say Miller provides this structure in 1990. And he says, you know, at the bottom level is this idea of knows. We should assess people's knowledge of things. So if you're interested in intubation, for example, actually, I'll use a very basic example. If you're interested in whether or not somebody can tie a shoelace, you might say here, you know, do they know what a shoelace is, what its origins are, where it came from, what it's made of, how long they are, things like that, knowledge piece. The knows how is, you know, can they apply that information, what they know, can they apply that? So in the shoelace example, it would be, you know, can they describe the process of tying a shoelace? So you take this loop, you do this, take that loop, you do this. Can they describe that? And can they do it with different shoes, you know, and different types of laces and different types of knots and things like that. So that would be the knows how part. The shows how part would be them actually taking the shoelace and a shoe and demonstrating for you on a table somewhere how to tie the shoelace. And then the does level is whether or not they can do this in daily life. You know, every day when they get dressed in the morning, can they do this, you know, bend over and deal with the issue of, you know, their gut in the way or whatever, that sort of thing. So applied to clinical practice, you would say, you know, intubation, for example, might be, you know, do they know what intubation is and, you know, maybe when it's indicated, things like that. Can they describe or can they apply that knowledge to various cases in terms of indicating who should be intubated and what tube size and, you know, how it should be done and those sorts of things. Then you put an intubation head on top of a table somewhere and they show you they can do it. And this is actually done in practice. Can they do this in practice? So ideally, if you're making decisions about competence, you want to say, we want to assess them here. Now, that's not always possible or feasible. I mean, it's very challenging for us to assess everybody in the field, so we go for second best, which is to do it at this level here. Now, the key is, if you're going to do it at this level, you have to demonstrate enough evidence of two things, reliability and validity, to make sure that it does a good job of predicting this part here. Otherwise, why would you? If this is a poor predictor of this process, then this process needs to be fixed. Okay, but the whole assessment community accepts the fact that if you do this right, it's a reasonable predictor of this piece here. Okay, so that's that first recommendation. So we're in this part here, but that's why it's important for the raters, because remember I told you earlier, there's 2 places this can fail, content and raters. We have to make sure that the raters are doing what they need to be doing at this level so that we can be sure that it predicts performance in the future. Okay, that's the first thing. The second recommendation is to say that if you're going to do it here, because it's so time-consuming, expensive, difficult, and challenging, we only do here what cannot be reasonably done here. So at these levels, you can do you can assess a lot of this through multiple choice testing, any sort of written exams, and so on. So because that can happen there, whatever can be done in these levels, just do in those levels. So for example, if you have stations that include ECG interpretation, you could probably get away with doing some of it here and it being a reasonable predictor of this level. But here you might want to see them decide when to do an ECG interpretation and interpret it and practice it and prioritize it and so on. So again, you can move things down here as much as possible, but there's just some things that you cannot move from this level. The act of intubating somebody, for example, cannot be moved down. Right? The third recommendation is about content specificity. Content specificity means that one case is not a very good predictor of the next case. Okay? And that's probably one of the biggest truisms that exists in assessment, performance-based assessments. So in other words, if you have an asthma attack, this is a very poor, a poor predictor of performance on a cardiac arrest, let's say, or an obstetrical case or whatever. Because of that, you need a certain amount of cases to be able to predict this level, right? So again, our goal is to predict here. So if I only had one case, and this is a poor predictor of this one, then I've done a terrible job of going from here to there. The question is, or the issue is, I need to have multiple cases, and the magic question is, how many cases do I need? Now, the base hospital has decided at this point they're going to go with 7 cases because the literature tells us that that's the minimum that's reasonable. Now, but as I said earlier, 2 things can threaten this process, raters and content. If the raters and content are bad, that number could increase to 9, 10, 11, 12, or 13. If they're good, then it can shrink it down maybe to 5. Again, I feel bad I keep putting pressure on Andy here about the content, or the content group, but us too as the raters, right? And I apologize for that. That's obviously a college computer, and they don't want me to turn it off just in case it doesn't turn back on, so. Okay, the fourth is to support claims of validity, ensure the assessment modality is as authentic as possible. So here, what you just saw there looked probably, with the exception of the overacting of some of the people in the video, was very authentic. It was in their environment, it was confined, it was a realistic case, perhaps, not common, but not too far out. And again, with the exception of the overacting by some of the people that were in there, you could see that happening. So that authenticity, again, because this setting is not authentic, it's not the real thing, this part is. The closer this can be to authentic, the better it is a predictor of that. Right? So we want to create cases, and the content group has done a great job of doing this actually, of creating cases that are very authentic. Contrast that with an intubation head on a table, and you can recognize that that's not very authentic, right? And so because of when you reduce the authenticity, as you decrease authenticity, you make it harder to allow this level to predict that level. So we want very authentic cases. So the group has worked extremely hard to make sure that those cases are extremely authentic. And when the people who go to put this together and create the cases for you and work with you to create the cases on the day of will do their best to make sure that it's very, very authentic. So this requires full clinical cases in our context, in paramedic context. It requires full clinical cases as opposed to chunked off things, right? So we want full clinical cases. Now you could argue that, well, you can't capture everything in a clinical case, and I would agree. We can start and stop them, where we want to, depending on what we want to assess. Okay, but the point is that we want to have as much authenticity here as possible. When preparing an assessment at the shows how level, it's number 5, ensure the construct is adequately sampled using a structured blueprint that represents the domains of skills and possible encounters. This is the piece that I probably annoyed Andy and his group and Steph and others a lot, because I kept harping on this necessity of a blueprint. which they completed and it worked out fine. But what the reason for that is because we have this, what we call a construct. So the construct in paramedic practice is defined a number of ways. In your setting, in a base hospital setting, it might be all the medical directives. It might be the national competencies. It might be a list of patient skills. It might be a list of patient types. It might be the BLS standards of care. You can go on and decide how this should be identified. It might be the MCAS syllabus, whatever. The point is we define it in some way, and then we have this big construct. And the challenge, again, because we can only have 7, 8, or 9 cases, the challenge is how do we sample that big construct effectively? And so this is the challenge for the content group again. They have to make sure that that collection of cases that we use adequately samples from that big construct. Okay, so the cases that they've selected is intended to do that. 6, where possible, use a response format that has been subjected to the rigors of psychometric analysis. This just basically has to deal with the tool that we're using. In this case, we used a global rating scale, but we can talk about the pros and cons of doing that a little bit later. Improve reliability by increasing the number of stations used at the show's HAL level. And we talked about that already. Because of content specificity, we want to increase the amount of stations that is feasible. And I would argue that 7 is on the brink of feasible. When you start to get up, we've done as many as 10. The students are quite burnt out by that. They're very tired by that, getting towards the tail end of that. So I think we're at a really good number here of working at 7. Conduct generalizability analysis. What we're going to do, so there's no test today, but when you do the assessment process, there will be a test after that, in that we will analyze your performance. And the way your performance will be analyzed will be in the overall reliability of the process, again, because that's totally dependent on the scores that you generate. And we're going to look at inter-rater reliability. So we're going to basically pair you up at some point, and you guys are going to assess the candidates, and then we're going to measure how much you guys agree or are consistent in your scoring. Now, the important thing is not that you agree totally. You don't both need to be at 5 and 5 or 6 and 6 or 2 and 2. It's just that you move together. So if you are a little stringent, a little bit more stringent than your partner, and you give a 3 and they give a 4, that's okay as long as that when we go to the next case, that moves together that way as well. So it's consistency and differentiation. I'm going to come back to those 2 points, consistency and differentiation a little bit later. When assessing the integration of multiple competencies in summative assessments, which is what you're doing, use global rating scales rather than competency-specific checklists. How much do I take into consideration this other context piece, all this other stuff that's going on around it? And I would say all of it. The entire context matters, right? So the global rating scales do 2 things. One, they allow you to take into a full context, and it's interested in both outcomes and process, not just outcomes, right? So I've had many conversations about this with people, and again, it's not just did they get to the defibrillation in time? Did they get to the drug in a certain amount of time? It's not just about that. It's also about the process that they took to get there. Okay? And this document, this rating tool, allows you to use your judgment to determine whether or not they've actually had the right process. So in our setting, we don't have any times. We don't structure in any times. We don't build that in at all. We're very interested in the process. Because you can imagine, to give you an example, if you have a patient who needs nitro, let's say, you can imagine a circumstance where you have a very fast person who gets there very quickly, knows instantly that, yep, this is a cardiac pain or cardiac scenario, it's clearly going to need nitro, let me give some nitro, they get it done in 4 minutes or something like that. It turns out to be the right process, the right outcome, the right treatment plan for that patient. That looks impressive, with the exception of the fact that the process that they took to get there can be severely flawed. Obviously. If they don't go through a rigorous assessment process, history gathering, and so on, then their process is flawed. And when you try to extrapolate to future settings, to novel contexts, in the absence of that process, if they don't have that process, they're dangerous. They could be dangerous. So that's what we're interested in. We're interested in the process as well as the outcomes, not just one or the other. Okay? So the generalizability studies for recommendation 8 will allow us to identify a few things. It'll allow us to identify whether you're a bad rater. It'll allow us to identify whether we have problems in the rater pool in terms of reliability. It will also allow us, to the content group's point, to determine whether the cases are problematic. And it'll also tell us whether or not the tool is problematic. So all those things will come out on the tail end after you assign all your scores. We'll take all that data, analyze it all, and those things will come out to us. What we do with that information then is a couple things. If we determine that the raters are bad, we just go back to rater training or try to identify what the problems were and try to fix that. If we find that the tool is bad, we chuck the tool or get a new tool or revise the tool or do something. If we find that the cases are bad, we just either add more cases or we recommend more cases or we correct the cases, adjust the cases, whatever. All that information comes out just from the scoring that you're going to do for the candidates that are going through. When assessing, we talked about this one already, the multiple competencies. So we're interested in, and correct me if I'm wrong here, but we're interested in, again, trying to be predictive of this level, we're interested in the integration of multiple competencies, and not isolated, decontextualized skills. Very, very different. The process of selecting when to do a 12-lead ECG, interpreting it, building it into your care plans, building it into your assessment plans, and so on is, I would argue, more important, well, not more important, but just as important as doing the skill itself, making sure that the lead placements are correct, right? That's the piece that we're after with this rating tool. That's the piece that you guys will be able to assess using this process. I'm going to talk about standard setting a little bit later, so don't worry about that process, but I do want to point out one thing. On the global rating scale that you have, that I've given you, you'll notice on the back page that there is an overall clinical performance category. And you filled it out, and I'm sure other people did as well. That piece, that overall clinical performance score, is not factored into their scores at all. That score is used for standard setting, and I'm going to explain that a little bit later. Okay, but that's used for standard setting. It's not used for deciding whether or not they're competent or incompetent. We talked a little bit about 11 already. Rather than assessing procedural skills in decontextualized skill stations, integrate assessments of procedural skills into the sample of cases used in the process. What this basically says is if there's 20 skills you're interested in, and I'm just pulling that number out of the top of my head here. So if there's 20 skills that you're interested in, and we only have 7 stations, then let's try to get as many of those skills into the 7 stations, but recognize fully that we can't get all 20. And that's okay, because if you do this part right, and you do this part right, it will be predictive of other things, other procedural skills in the future, okay? Because they essentially have to prepare for all of them. That one sometimes people have trouble with, but we can talk more about that if you like. Number 12, if ongoing assessment of competence is to continue given known constraints, action must be taken to ensure scores generated using a 5-year sampling plan. So that's something that we would do after the fact. And then consider merging resources with other base hospitals, which you've obviously done, and you're all here. So that's the foundation that has been put forward to help build this process. So any comments, questions, thoughts?
Just the importance when you're saying that the sample that you're taking is going to be predictive of the whole because they don't know what they're being sampled on, relies on the protection of your cases so that they don't know what they're going to be testing.
Yeah, if they know them, then yeah, you threaten the process for sure. Any other thoughts about any of that? Context specificity is an important concept. I want to make sure you get that. And that again is that one case is not a good predictor of the other, so we need multiple cases. So on that point, I want to tell you about the way the assessment process is built. And I'm assuming that you have some information, but maybe not all of it. And so if I'm boring you on this, just let me know and we'll move forward. So you're going to have 1, 2, 3, 4, 5, 6, 7. And there'll be 2 raters per station. There'll be 7 stations. I forget the timing. I think we said 12 to 15 or something like that.
20-minute scenario. Time frames?
Yeah, how much is the case itself?
The case is 12 minutes.
12 minutes, yeah.
Well, 12, 14.
Okay, so we'll say 13 minutes or so. 13 minutes, 7 cases. It'll be a shotgun approach. Students will show up. They'll all come in, start at a different station, and move through them until they're done. What that means is, unlike some other health professions who rely on this one to do this one, that's not our case at all. These are completely independent, and people will just go through them in random order. It doesn't make a difference. okay? Now, the way they're scored, so I'll just put that aside for a second. You have 7 dimensions. So you have situation awareness, history gathering, patient assessment, decision making, resource utilization, communication, and procedural skill. Those are the 7 dimensions that are on the rating tool. These 7 dimensions, and then you have candidate 1, 2, 3, 4, 5, and so on. These 7 dimensions then are going to be, you're going to assess each of these 7 dimensions for each candidate. So each candidate will be assessed basically 7 times on each of these dimensions, okay? The way we eventually score, so if you can imagine these, so up here there's 7 dimensions, 7 dimensions, 7 dimensions, 7 dimensions. They don't pass or fail a station, okay? So we don't take these scores, and then, let me change this actually, let me backtrack. So let's say this is 1 student, okay? All 1 student, this is station 1, so I'll just put up here, station 1, station 2, station 3, station 4, station 5, and so on. We don't take each station and come up with a score, okay? So they go through the stations here and they come up with a score. That's not what we're interested in. We don't average these scores, situation awareness, history gathering, patient assessment, decision making, and all these dimensions together and come up with an average score. That's not how it's done. So people don't pass or fail a station. What we do is they get in station 1, they get a score. In station 2, they get a score. In station 3, they get a score. Station 4, they get a score, and so on. This is the score that we're interested in. Across 7 stations and 7 different raters, what is their situation awareness score? Now, you're assessing all the dimensions, right? But we're interested in across 7 stations, across all the 7 raters, in this case 14 raters because there'll be 2, what is their final score regarding situation awareness? We do the same for history gathering, we do the same for procedural skill, or sorry, patient assessment, and so on. So what we interpret this to mean is 7 people, so you can imagine a situation where you have 2, 1, 2, 3, 2, 1, you know, somewhere around 3 or 2.5 or something like that. If that's the final score at the end, we can basically say to the student or the candidate, we could say, look, 7 people told us you have poor decision-making skills. And those decision-making skills were exhibited across a bunch of different cases, right? So it's not that you had 1 bad case you didn't understand. It's not that you had 2 bad cases you didn't understand. You had 7. And 7 different people who didn't know what the other scores were told us the exact same thing about you. So that's how it's scored. Decision-making, patient assessment, and so on is all scored. And then the average of all the 7 stations per dimension is what we care about, okay? So again, they don't pass or fail your station. You're not passing or failing anybody. What you're doing is contributing to a picture of that person across those 7 dimensions. So when I say that, what that means is you should feel freedom to score appropriately, right? Because you're not making decisions about these people, about passing or failing these people. You're just contributing to a picture given your context. Now, we intentionally built, and you won't know this probably going in, but we intentionally built the care. They intentionally built the cases to have varying levels of difficulty. One of these cases will be very, very challenging. One will be very, very easy. And the other ones will fall in between. And so you just have to, depending on the case you have, you just score it as you score it. And again, treat each dimension on its own merit. So you can feel free to give a really bad decision making, but a really great communication score, okay? The other thing we don't do, or the scoring strategy also includes something called non-compensatory scoring. What that means is we don't allow exceptional communication scores to compensate for bad decision making. We will tell the candidates that they basically, this is a policy decision more than anything. They need to pass all 7 dimensions. They need to reach a cut score for all 7 dimensions to go forward, because we are saying that these elements are what make up the construct of paramedic practice. If you don't have one of them, then maybe you're not ready yet, right? So imagine a situation where they really don't have any situation awareness. They gather information and they do assessments and things, and they can go through all those steps, but they really don't understand what's happening in this case. That's not somebody we really want out there. Same thing for if you have somebody who can't communicate, but they do all these other things wonderfully, but they're so terrible at communicating with the patients. We don't want those people out there either. So this basically, all these dimensions, they have to pass all of them to get through. And so we don't allow one to compensate for the other. Okay? Yeah, there is no process by which to say you must have 75%, 65%, and it must be selected in this way. It's totally expert opinion. And those things will change from offering to offering. But yeah, I mean, one of the things I gave to the content group was, after the blueprint was done, I said, here, have a look at it now and agree. Are you happy with it? Is it representative enough that you're comfortable? And it's never 100%, ever 100%. So yeah, it's totally up to them. Yeah. Now I want to throw in a word of caution here because what I feel like I've done is I've moved to another end of the spectrum here. And that is the experts and novices, there's differences among them. And the difference is basically when you compare these two groups of people in diagnostic error or clinical reasoning or something like that, is that they can get there a little faster. Like anybody in this room, for example, if you go to a call, your history of experiences and patterns and those sorts of things will help you be efficient. You build schemas around this types of patient interactions, and so those schemas that you build over time will help you be efficient. Now that's not to say that you're going to cut a ton of corners here, just that you'll be more efficient. You don't have to follow the step one, question two, and so on. And so again, but the rating tool allows you to adjust for that. And you just have to be careful that that somebody who's very, very efficient is not automatically assumed to be cutting corners and process to be bad. That there might be efficiencies there because they're exceptionally strong or experienced or whatever. So you just have to, I just want to throw that caution out there because I don't want to make sure that we don't go too far in the other direction, okay? I wanted to just, again, provide some structure for us to think about. So you've been introduced to a couple things already, Miller's pyramid, the importance of shows how being predictive of the does level, the importance of context specificity, and now we're going to get into more the rater piece, and we're going to talk about the act of rater-based assessments, just broadly speaking to break that down a little bit, and then we'll get into where the rater, or how the rater affects reliability and validity. So those are the two psychometric properties that we absolutely need. So I'll define those for you now, and I'll define it again. So reliability is the ability, so most people think about reliability, if you're thinking about it in layman's terms, you would say my car starts every morning, that's a reliable car. Or that reliability be perfect agreement, right? So if we have perfect agreement, it must be a reliable process. And in our setting, in assessment of competence, that's not the definitions we use. The definitions we use is the ability to do two things: consistently differentiate. You have to do both. You have to be consistent, and you have to be able to differentiate. Okay, so just let those two things sit in your head. You have to differentiate. What I mean by differentiation, consistency is self-explanatory. It's just that you're consistent as to when you give a 5, when you give a 3, when you give a 2, and so on. If you're inconsistent, then you start to introduce error to the process. The differentiation piece is basically if I give you a pool of 10 candidates, can you identify the strongest and the weakest and the ones in between? Can you rank order them properly? Okay, so that's the differentiation piece. And we're going to give you ways of helping you do that, but the point is that's your task, those two things. Consistently differentiate. So the active rater-based assessment, basically, if I was to, in the most simplest terms, if I were to break it down into 3 areas, I would say here we have the cases. Here we have observation. And here we have, I'm just going to call this translation. So in the cases, the content group puts the cases together. That's, the reliability and validity issues around that are their own. They deal with that. They build the cases. They're all sitting there. And what this will do is this will cause certain behaviors to be exhibited, right? So the candidates will come in. Candidates will come into the case. They'll have performance schemas in their head already in terms of what's right, what's wrong, how to do what, and so on, depending on what they've been taught and learned over the years. And so they'll come in and they will exhibit behaviors in here. We have, after the content group is done, we have no control over this as raters, right? Just, it is what it is. The cases are what they are. The behaviors get exhibited as they do. That's just it. We have no control over the way that what behaviors are exhibited and the sequence in which they do and so on. There's just no control over that. This thing happens all by itself, and that's all dependent on the content group. Now this part here is where the raters come into play here. The raters have a task now of observing all of these behaviors. And now let me tell you that we know, the literature knows, and this is my area of research, that you can't possibly see every single bit of information in that video. It's just not possible. Your brain can only handle so much information. Your attention and your working memory can only do so much. You can't see everything, but there are lots of things you can see, and you can control what you see and don't see. Okay? So, but the raters work here, and they observe, and they observe, and they observe, and they process and process and process. For example, does it matter the sequence in which that person performed? Does that matter? This behavior was done well, but this one was done poorly. Does that matter? And how do I weight that in my own mind? So all of this is going on in your head there. Should I pay attention to that or should I pay attention to this? Do I detect this or detect that? All of that's going on. And so this is all happening here. And so we need a way to control that to some extent and recognize again that it's never going to be perfect. In other words, you are not this objective measurement device simply capturing everything that's here and translating it to a rating tool. You process the information. So we consider raters to be what we would call cognitive filters. You're a filter in the process, and so we just need to work with that as opposed to resist it. Okay? So you go through this entire process here, and we'll work more here in a little bit. And then after you observe it, and you've already done this process, so in the video that you watched the first time around, you went through, you had no control of this, you did this, you observed as much as you could, given however you normally do that, and then you participated in this process, which is you took all those thoughts, all those things that you saw and observed and remembered and so on, and then translated that into some sort of score, right? That's the process. So there is error that gets introduced here, and there is error that gets introduced here. So the translation process is problematic, and this process is problematic. And so these are the two pieces we go after in rater training. Okay? So those are the two things that we're interested in. So this is a very simple view of the act of rater-based assessments. Okay? So now we're going to talk about reliability and validity. So reliability, we said, was the ability to consistently differentiate. And so I want to, again, give you a sense of how you affect those two things, reliability and validity. So there's no math test today, but basically the way reliability is calculated is you have variance, I'll explain this in a second, divided by variance plus error. Okay? And so this is basically how reliability is calculated. And there's ways of determining what the variance is here and there, as well as the error. So your role is to create this. Okay? So your role is to generate as much, now I shouldn't say, what I was going to say is generate as much variance as possible, but not artificially. So we don't want to artificially put a huge range of scores in, because that wouldn't be accurate either. The point is we want you to differentiate between candidates. We want you to, if you assigned everybody a 5, let's say, 5, 5, 5, 5, 5, 5, 5, the variance here would be very small. It would be 0, actually. There would be no variance. It's just 5, right? It doesn't move from there across all candidates. So if you have a bunch of candidates and you give a 2, a 5, a 7, a 3, on and on and on, now we start to have some variance. Now we start to have some ability to differentiate between people. The error comes in, there's multiple sources. So that's the first point, that you have to feel some freedom. Again, remembering that you're not passing or failing anybody, but you have to feel some freedom to be able to use the scale in its entirety. Okay? You shouldn't be afraid of that. Some people are afraid to use the top and bottom ends and things like that. You should feel comfortable to use the entire scale. And again, your goal, you have to know that your goal is to be able to differentiate this candidate, from the next candidate, and so on, without knowing what's coming. You just have to be able to differentiate them based on the case that you're watching. Now, it could be that you have people that perform very consistently. If a very homogeneous group, for example, if you take, one of the benefits is we're going to have in this pool of candidates a number of colleges represented, perhaps even some experienced paramedics coming through the process or not, I don't know. But the point is you're going to have lots of different backgrounds in these people. And so they will differ for sure. And even Andy was telling me the other day that sometimes even from the same school, they're very, very different. And so that should result in an increase in variance. And I'm going to show you in a little while, if I could pull it up, some hypothetical data to make the point. okay, so that you could see this formula sort of come to life, if you will. I'll show you that. But the point is here, in the error part, this is where it starts to threaten the process. And reliability is an indicator of how much error is here. Because you can imagine if you take 1 divided by 1 and have 0 here, reliability is 1, and that would be perfect. The issue is it's never that. There's always a level of error in the process, and the idea is to try to control this as much as possible. One of the sources of error, the most talked about and the one that we're concerned about here, is radar. Radar error comes in when you introduce things to the process that shouldn't be there. For example, if you hold a view about medication administration, and you introduce, and you bring that view to the rating process, and you say, there must be done in 4 minutes. If that's not true of the construct of paramedic practice, and you bring that to the rating process, you've introduced a level of error. Now, we're speaking hypothetically here and theoretically, but just you get the sense that you bring things into the process. And the more you bring into the process, the more this could potentially become a problem. So I'm going to explain a little bit later all the different types of radar error that can happen, and then we can basically try to target those and avoid those as much as possible. I'll just give you one right now. What would be a good one to talk about? Leniency. Leniency, medical schools have this problem, especially when it comes to observation of medical students or residents in actual clinical settings. Nobody fails. They just put them all at the top end of the scale. And so that's a very lenient rating process. And that lumps everybody at the top. And again, you don't have that ability to differentiate between people because you've put everybody in the same bucket. Stringency is another one. If you're marking everyone harder than they should be, then that's problematic. So let me show you what that would look like. So again, theoretically speaking, if you have a spectrum of performance, this is very, very bad. This is great. And the student is truly here, right? Now, we don't know what their true performance ability is, but if they are truly there, if somehow we had a magic X-ray machine that could see what their true level of competence is, and it puts them there, if you bring in a stringent rater, it might put them down here. And that difference is the error. If you have a very lenient rater, you might put them up there, and that could contribute error as well. If you have really easy cases, you might move this up here because the cases are so easy. If you have really, really hard cases that, well, let me put it this way. If you give them a test on auxiliary directives and they weren't taught on auxiliary directives and they perform poorly, that might not be a true representation of their true performance ability, and we've moved them down here inappropriately. If you give them a mannequin that they've never used and never interacted with and have no concept of where the pulse points are, auscultations, and so on, and they make errors because of them, you move this person down here because of that. These are all threats to reliability and all threats to validity. What I'm talking about here more is validity. So validity is not a number necessarily, it's evidence. How much evidence can we accumulate to demonstrate that our assessment process is working like it should be, right? That the scores we generate, so if I give a student a score of 5, how much evidence do I have that that score of 5 is appropriate, is accurate, that the inferences I make about that score are appropriate? So if I decide that somebody's a 5 is competent, how much evidence do I have that that's actually true? Okay? So you've probably heard the word validity before, and people would say it as, does the test assess what we expect it to assess? That's sort of an old thinking of validity. And here we're saying, how much evidence do you have to defend the inferences you make based on the scores that you generate? So we're going to generate scores about these people, and then we're going to make a decision about them based on those scores. And then the validity question is, how much evidence do we have that that's accurate, that those inferences are accurate? I feel like I'm a little too hypothetical at the moment, but we'll bring you back down a little bit. So the cases, the raters, all of that can affect the validity, the decisions we make about that score. Because if the cases have a mannequin that they've never used and they struggle with, then that's not part of the construct, and that's moved the score down and affected the construct. So we've added something to the construct that's problematic. So let me give you another visual to think about. So let's just assume this wheel here is the construct of paramedic practice. And let's just say there are pieces to that construct of paramedic practice. So we can use the ones we've had so far. decision making, resource utilization, situation awareness, history gathering, patient assessment, and communication. Thank you. Which one am I missing? 3, 6.
Who invented this thing?
I'm missing procedural skill. You would think I would have that all. Okay. Okay. So 6 pieces. That just kind of worked out. So yeah, procedural skill is missing. So this is the so if we only have, so if the 7 are the construct of paramedic practice, and we only assess 6, then we've underrepresented the construct because procedural skill is missing. Right? You don't have the full picture. If I added something in here, like an additional piece, I don't know what I would put here. Teamwork is bad, but let me just use teamwork for now. Multidisciplinary teams, right? So if we said, this is such a bad example, but anyways, if you put something here, if you add something to the process that shouldn't be there, if there is something in that rating tool or something in the cases that shouldn't be there, you overrepresent the construct, and now you affect this movement, okay? So the cases have to be truly representative of the construct that we're interested in. The rating tool has to be truly representative of the construct we're interested in, and you have to see them both that way as the raters, okay? So this is some more conceptual stuff. One of the questions that comes up is you build this scale, and then you're like, well, you know, is communication really, and we would debate this forever. Is communication more important than patient assessment? Is patient assessment more important than history gathering or situation awareness and so on? And people have played with this forever and have adjusted and applied various weights to the whole process and recognize at the end of the day, it doesn't matter. We weight them equally, and that kind of manipulation of weightings across doesn't come out in the end, after all the analysis and so on, to demonstrate that that's any better, that doing that results in a better assessment process. So you shouldn't worry about that. The way you approach this is you just look at these dimensions and say, they're all important, they're all part of the picture. If you don't have one of them, you're not a paramedic. That's basically it. But that's a great question, very important one. So let me tell you a little bit about how this scale was put together. First of all, it involved as many organizations as we can feasibly put into the study. We had base hospitals, we had colleges, universities, clinicians, employers, private schools in other provinces, and we literally went from coast to coast. Every province was represented in the development of this tool. And what we did first was we took a number of videos like this and real clinical performances and went out in the field and so on and tried to break down as much as we possibly could all these different performances. We took every little piece, every little thing that we could think of and put it down and came up with basically 250 something, if I remember correctly, 257 different behaviors that go on in a patient interaction. We then took all those 250 behaviors, I forget how many performances we watched, but took all those 250 behaviors and then started to put them into buckets. So this one is a patient assessment behavior, this one is a history gathering behavior, and this one's a procedural skill behavior, and so on. And then we came up with actually an 8-dimension. So we came up with 8 buckets, basically, initially. And then we assembled a bunch of experts, again, from coast to coast, and gave them the tool, and gave them all the little pieces, the pieces that informed each bucket, each dimension. So here, have a look at this, think about it, apply it in your setting, tell me if it's working, not working, what's missing, what's not missing, that sort of thing. You know, just use it for a little while. So they did that. They went through a process, and we engaged in a process called the Delphi process, which is a way of gathering information and building consensus or getting to consensus. And so we did that. We collected all these things. And then we had, and so people generally agreed that all this was appropriate. One of the things that came up, actually, 2 things, was the other dimension that was on here that's not on here now is implementation. People felt that the decision-making process was conceptually different than actually applying it. You might make the right decision, but the way you actually carry it out might be problematic. And so initially we had this fight. We couldn't agree on whether or not these 2 things should be 2 different things, right? Like, you could easily argue both sides. You could easily argue, decision making is one thing. You may say, okay, I'm going to, shock this person, and then it takes you 3 minutes to get to the shock, and the implementation of that decision is problematic or whatever. And the other side, so that's arguing that side. Arguing this side, you might say, yeah, but you can't tease those apart. Like, they're kind of tied together, and so if they can't tease them apart, then what do you do? So you might penalize them twice as opposed to once. So anyway, so what happened? We left it in because we couldn't agree. We put it in, and then we applied it to a study. Basically, what it involved was 80 different performances of 3 groups. We had students at the end of year 1, students at the entry to practice level, which is the people you'll be seeing, and then experienced paramedics with less than 5 years but more than a year. And the reason why we went for less than 5 years is because we didn't want age to come out to be obvious to the raters. You know, if you have really old people, you know, they see them as more experienced, I guess. So everyone looked young, basically, in these videos. And this was one of the videos. The video you scored earlier was one of the videos. And so then we just had raters score it. And what we asked, what we were interested in, does the scale, they watched it like you did and scored a bunch of videos, does the scale differentiate between those 3 groups? And we found that it did. So that was the first thing. So we're like, okay, thank God it can differentiate between those people. That's a good thing. The second thing we did was something called an item analysis, was to look at the correlations between all these dimensions. Dimension 1 and 2, 1 and 3, 2 and 3, 2 and 4, you know, and so on. You look at all those correlations and you look at to see if any of them are redundant. And the 2 that were most redundant was decision making and implementation. In other words, the raters couldn't differentiate between those categories. You can imagine differentiating between decision making and procedural skill, very easy. The decision to do it is one thing, doing it hands-on, injection stuff, whatever, is totally something different. So raters could figure that part out, but they couldn't differentiate decision-making and implementation. So when you have that, when you have high correlations between items, it suggests that they're redundant, we remove one. So implementation came out at that stage, and we're left with this. And what the scale tells us is that these dimensions, and you may agree or disagree, but these dimensions adequately capture the construct of paramedic practice. So that's what we're saying by presenting this to you. And that there's nothing missing here. Now the reality is, of course, there's things missing. For example, there's nothing in here about driving, you know, and that's part of the job, you know. There's nothing in here about professionalism, really, and that's part of the job, you know. So there are some things, compassion, you know, for example, that's part of the job, and that's not in here either. So there are some things that are missing, but from a clinical perspective, this was as thorough as we thought it could be, okay? So now let me take you through this, the parts of this, the anatomy of this tool to some extent. Each dimension has a description below it. Initially, the tool used to include bullet points. And the problem with including bullet points under each one is that people then treat that like checklists. They say, did they have that bullet point? Did they have that bullet point? Did they have that bullet point? And so on. And so that's problematic because that's not the intent of the scale. So it was converted to a paragraph statement, and this is intended to give raters a similar view about what situation awareness is. When I would talk to people about situation, the first thing they would say to me is, oh yeah, they did a scene survey, they did that. And that situation is not just that, it's much bigger than that. So we tried to define situation awareness as much as we possibly could, and that's the definition that we put there. Very important that you adopt these, conceptually, you adopt these definitions as yours. And that you become familiar with them enough that you don't need to go down and read them. So the first few times you'll have to do that to really make sure that you're understanding it. But over time, you won't need to do that. But initially, I would recommend that you absolutely spend some time reading that definition. It's very important for Deb and I to have, for example, the exact same understanding of that dimension. Otherwise, when we watch the exact same performance, we'll score it differently. And then who's got it right? Like if this is the true score, true performance score, and we see things differently and Deb's there and I'm here, you know, who's got it right? So it's very important that we agree. This is the consistency part of reliability, that we agree on what the definitions are. Okay, so that's the first part. So you'll see every definition has one of those, and again, you'll just want to familiarize yourself with it. One of the biggest problems we have with raters we use is they don't take that step. They just use what they think they know about and what they do know about history gathering, patient assessment, and so on. And they apply their own definitions, and that becomes problematic. So the first step is you have to read these definitions, understand them, accept them, and build them into your sort of thinking about it. Okay? If for no other reason, just for the assessment process, you don't have to adopt them, you know, outside of that setting, of course. It's just to get us consistent, just to go have us thinking consistently. So this part is what we would call performance dimension training. The performance dimension is situation awareness, And the training basically involves just simply having a similar definition about it. Now, normally people who don't, rating tools that don't have that piece in there, will do the training outside of that and then assume that you have it. And we just built it in there so you could reread it if you had to. That's all. But there's two types of training that we're going to talk about, three types that we're going to talk about today. Rate or error training, which we talked about how errors are problems. So I'm going to talk about what threats are there. Performance dimension training, which is what we're doing right now. And to Andy's point earlier, which was up here, frame of reference training. And we're going to talk about that. So right now we're just going through performance dimension training. So you look at the definitions, that's the first step. Make sure that you understand them, you agree to them all, and you can remember them and apply them. The next piece is the rating, the score from 1 to 7. So the 7 dimensions, the 7 points there, the first question, or one question you might ask, why do you have 7 points? And when we were building this, this is a policy decision, this is a psychometric decision, it's not something that the expert panel agreed on. Some of them wanted 5, and they wanted 5 because 3 out of 5 is 60%, and that's what my pass score is at my college or my institution, and so I want a 5, right? And giving a 4 out of 7 is 57 point something %, and that doesn't help me because, what do I do if my pass score is 60%, So that created problems for them. And I would say to you, forget the scoring totally. That's not your concern. Where we set the cut score is something else. Don't worry about it at all. But what 7 allows is for you to differentiate further. So basically you have 7 categories to choose from. If we reduced it to 5, you would only have 5 categories. If we reduced it to 3, you'd only have 3 categories, and this gets smaller and smaller and smaller. So when you and remember that the formula is dependent on that. How much reliability we can get is dependent on that. So 7 gives us 7 buckets. So the next question might be, well, why not go to 9? And the answer is 9 becomes very difficult for raters to differentiate. To really draw the line between a 6 and a 7 even is a difficult challenge. And a 5 and a 6 and a 4 and a 5 and so far sometimes can be difficult. When you move it to 9, it gets even harder. So this is the 7 is as far as we can go. Now there are statements below it, unsafe, unsat, so on, but if I could do this again, I would remove those statements because those statements carry value to you, right? So, and that's a mistake that we made and we can't really change now, but that carries value to you. When you read the word marginal, you're like, okay, this guy's you have your own interpretation of what marginal is, and you apply that to what you just saw, and you're like, okay, I think this guy's, maybe I might move him through, this guy's marginal. And so people adopt their own definitions, and that we don't want that. So if I could remove them, I would, but it's okay, as long as you understand what they're doing there. All they're doing is providing a reference back to the top, which is up at the top, it says rating labels and rating label definition. If you look at the rating label definition, these have been structured in a couple of ways. These have been structured around consistency to a standard of some kind, and then they've been structured around whether or not they're suitable for supervised practice or progression or graduation or something like that. So let me read one to you. So for example, marginal. It says occasionally performance is to standard, so there's the reference to standard, and or performance meets minimum standards, there again is the reference to standards, improvements recommended, suitable for supervised practice or progression with some remediation. This piece here, suitable for supervised practice or progression with some remediation, is probably the most relevant to our context here. That's the piece that I would want you to attach yourself to. So when you're watching a performance, you think to yourself, okay, I just watched this, I have a view, I have a thinking on this, I read the definition and I say to myself, yeah, they're suitable for supervised practice, but no further. I wouldn't let this person work on their own. And those statements have been built intentionally to try to align with how you naturally think about stuff. Now this scale was built for colleges and for this level, base hospital level people. So, some of the language is to satisfy both sides around progression, for example. But here we try to align with your thinking as much as possible. So just when you come up with a score, when you're thinking of situation awareness, you read the definition, you come up with where you think you are, maybe a 3 or a 4, go back up to the rating label definition, read the rating label definition, ask yourself if it's true, and then go up 1 and come down 1 and see if it's still true. Right? So if you think you're at a 4, read the definition for 4, go to 3, go to 5, read those, and then determine whether or not you think you're still at a 4. Okay? And try not to attach yourself to the word competent, highly competent, exceptional, those sorts of things. Really attach yourself to the definition. So that's the practice. You learn definition, you watch the performance, you come up with a score intuitively that you think is there, go up to the rating label, read the definition, go up one, down one, decide where you should be. Okay? The next piece is the way you should consider each dimension. The way you should consider each dimension is independent of all others. In other words, you have to do your best. You have to do your best to not allow your communication scores or your assessment of their communication skills to influence your decision-making scores. These have to be treated totally independent. And one of the things we see sometimes is people will observe the performance, come up with a Gestalt type view of this. Overall, I think it's this. Say a 5, and they read the label, the rating label definition. They say, okay, yep, definitely a 5, and they go 5, 5, 5, 5, 5, 5, 5, 5, 5, right? And the problem with that is if you think back to our scoring strategy and your requirement to differentiate not only between candidates but also to differentiate between dimensions, these dimensions, it totally invalidates the whole process. If you allow a general impression to assign scores to everything, when we go to average them across, it invalidates the whole process. So you really have to do your best to think of each one by itself. And the way I often tell raters is to say, you're at situation awareness, think of situation awareness first, come up with your score, put that out of your head, think about history gathering, just history gathering, come up with a score, move on, and so on. And try not to really just apply this overall impression. Now, the overall clinical performance piece, again, is now this is where you get to apply your overall Gestalt. And people here, for the most part, will simply just take an average of all their scores, not intentionally, but subliminally, I guess, subconsciously, I should say. They take the average of those scores. However, it doesn't matter. The point is that you come up with an overall Gestalt impression about this person and assign a score. We will then use that score to establish cut scores, the overall category. It's not used in the decision-making about the person, about the dimensions. It's not factored in, but it is factored into a cut score strategy, which I'm going to describe a little bit later. Okay? So again, treat each dimension by itself. Be familiar with the dimensions. That's the performance dimension piece. Always go back up to the rating label, go up one, go down one from where you think you are, and then assign your score and do it one at a time. Because we will come up with the cut score. There's a way of doing that. And all your job is to do is not to think about whether or not this person is passing or failing. You're just there to share with us your view of their performance on here using the language of the scale here. And it's only to align with your way of thinking. So there's basically two ways you can come up with the cut score. Well, there's lots of ways, but the two ways that I would present here is there's a statistical way, which is the way we're going to approach it first. And then the second is to use the language of the scale. And when colleges or other places call me about this and they say, oh, I want to use your scale or the scale, it's not mine, but the scale, but I struggle with this, 4 is 57%, what do I do with that? Or the language is what you just brought up, so it has to be a 5. When that happens, and they don't have the numbers to do it statistically or the knowledge to do it statistically, we say use the language of the scale. And then, yes, make the 5 your cut score. So when we were building the cases, we said to the content group, we said, make sure there's an opportunity to assess all these things. If it can't be, for whatever reason, so let's say there's no resources somewhere, or they're by themselves and it's a first response and there's no one to talk to and nothing else to do, then we would just omit that resource utilization score from the overall calculation because there's nothing to assess. The problem is when you do that, you now make it a 6-station score for resource utilization. It's not the end of the world, but it's something that we would have to deal with. So, but you bring up a good point. If decision-making has 10 decision points in the case, but resource utilization only has 2, then how do we deal with that? And the answer would be just as you came up with, which is basically score it on the observations that you have, assuming that you capture all the ones that are there. Just score it on what you've observed, and these things get worked out when you consider 7 stations. It's not a concern. The only time we don't want you to assign a score is when there was nothing to observe. So if there's no procedural skill, so we often get faculty in our group will say we want to do a case that involves purely communication, and I say, oh, that's fantastic, that's a great idea, let's do that. But just recognize that we're losing 1 station of procedural skills, we're losing 1 station of resource utilization, for example, or something like that. So that's just the cost benefit. So if you only have a certain amount of behaviors, you base it on whatever behaviors you have. Now, the important thing is, though, that you consider all behaviors. And I'm going to come back to this later, but you have to consider all behaviors for that dimension and not one to the exclusion of the other. But I'm going to park that for a second and come back to that, because that is a very big issue that we have to address, and we're going to disagree on for sure. So let me give you an example, because the cut score seems to be something that sits uncomfortable with a lot of people. We often see across the 7 dimensions varying cut scores, okay? And so you might say, well, why? How's that possible? And the reason is because you have a couple things. You have case difficulty that comes into play, and you have rater leniency and stringency that come into play. Those things can be accounted for in the cut score calculation. So that's why we don't tell students in advance a 5 out of 7, a 4 out of 7, or whatever is what you need to pass. We just say cut scores will be calculated. You need to achieve a cut score above the cut score on all of them. And when we calculate cut scores, we take into consideration rater stringency, case, or we rater and case effects is all we say. And that's the Medical Council of Canada, for example, that's exactly how they do it. That's what we will do. And again, the decision is going to be made by the base hospital, not by me. I'm just presenting data, and then you can decide from there. And it will be, the first time around, it will be a play of, okay, what do we do with this? And the other part I should mention is, when you come up with a score, let's say we decide the cut score should be 4.8, whatever. We say 4.8. There's a degree of error around that too. So maybe you could make a mistake. One of the things we want to avoid are false positives and false negatives, especially false positives for the base hospital. So one of the things that could happen is if we said that the score should be 4.8, there's a margin of error around that if 4.6 might be okay and so might 4.9 or 5. So we account for that as well and allow for that issue to be dealt with. And typically what happens is, and I'll give you a very simple example, you are much better as a group, I know this already, at determining decision-making performance than you are at communication. Communication is the hardest thing out of all of these here to score. Resource utilization, for example, is also very easy. You know when the resources are being used well or not, but the communication piece we always see people struggle with. They have a real hard time figuring out the communication part, because sometimes it's more than just the words, it's the timing, it's the intonation, it's a whole bunch of things that come together, and we struggle with that, to assess that. And some people argue that because it's so difficult, it should be assessed all by itself. So we already know that that's a problem, and because of that, the scores are always higher on communication than they are in decision making, because you're so much better at differentiating decision making than you are at communication. So because of that, we have to account for that. We deal with that. Yeah. I want to reflect back on the first scoring that you did. And now that you've heard some of this stuff, does anything come to mind that's worth raising at this point? So for example, did you review the dimensions in detail? And you don't have to answer this question. These are rhetorical questions for you just to think about. Did you review the dimensions in detail or apply your own understandings of them? Did you read the rating labels in detail or apply your own definitions of what marginal meant and what competent meant? Did you, and if you did read the labels, did you go up or down one when you did that? So if the answer is no to all those things, then it's likely that you and your partner, whoever the raters are going to be different. And now that you have the same performance dimension, understanding, which is written on the scale, and now that you both go up to the rating label and go up and go down one, and when we provide more detail about how to deal with the multiple behaviors that go on and all that stuff, when we deal with all those things, we'll just keep getting closer and closer and closer and closer to being able to agree on what the score should be. So the next thing I'm going to do is get you to score another video, very similar to the one that you just watched, but to use some of the things we just talked about. And then what we'll try to do is maybe have a way of looking at the first scoring, looking at the second scoring, see if we've come together at all. And if we aren't together, we want to identify why that might not be, or why that is. And that should hopefully raise some issues that we need to target specifically. After that, I'm going to give you a sample of a case that's going to be exactly the same format as what the content group has put together. And what all we've talked about so far, I mean, we've talked about a lot of things, but all we really targeted was performance dimension training. We've gotten to performance dimension training and then all the foundations around it. The next piece we're going to get to is the frame of reference, is what Andy brought up at the beginning. He said, well, I need some sort of frame of reference. And the content group is building that frame of reference for you. And so at the break, somebody asked me a question. They said, well, I see things my way, or I have a view of, seeing how the performance should unfold. We all do. And the frame of reference training piece, or the frame of reference piece, is how that gets us aligned on that level. So we're getting aligned so far on how to implement the scale, how to interpret the information, all that stuff. The next piece is to get us aligned on how the frame of reference or how the performance standards should be considered. And the content group has done that work for us. So the question was, you're observing a candidate, situation awareness, for example, and you see 7 behaviors that are relevant to that dimension. You score them. You go on, next candidate comes in, they do a few more things that you didn't even think of in the previous one. Do you go back and adjust the previous one because of this newfound knowledge? And so some people will argue in some contexts. So for example, we've done work with looking at non-clinical attributes, things like conflict resolution, social intelligence, emotional intelligence, things like that. And in that setting, the people who have done that work for a long time will say it's okay to go back and do those adjustments. In this setting, we would say that it's probably not ideal that you do that, and that it's perfectly okay to assess the individual based on what they did and what you observed there and those sorts of things, and to treat them as a bubble and then move on to the next into the new bubble. And in fact, try not as much as you can. So that, yes, because that's called contrast error. And so contrast error is basically looking at one, next person comes in, you compare them to each other, next person comes in, you compare them to the whatever. And so we don't want the frame of reference to be the previous candidate or candidates. We want the frame of reference to be what we tell you it is. And we're going to give you that in the cases. So as much as possible, just move on. You scored that one, do your best there, move on, do your best there, move on, do your best there. And it's all going to be relevant. And there will always be circumstances where you're going to miss something. It's just human nature. What I didn't share here is the way this, so if this is the formula for the scores that are generated plus error, the way to deal with this error is divide by n. And so if the error is raters, the more raters you have, the bigger this becomes, the smaller this becomes a factor. So that's how it's addressed. And whatever error that is. If you remember, I talked about context specificity. If you only have 3 cases and there's a lot of error associated with that, we add cases. And it reduces the effect that this has. So the rate of variability that we see, part of it is addressed by adding raters. So the way I would phrase it is I would say multiple raters, multiple contexts, multiple cases is a strong process. One case, one rater, or even one case, 2 raters is worse than 2 cases, 1 rater per station. So let me say that again. Because the way, if I could draw this for you, and this is reliability. Leaving me for a second there. That's 1, that's 0. This is 1 case, 5 cases, 10 cases. And I'll use black to indicate 1 rater, and this is challenging my brain here for a second too. But if we had 1 rater, 1 case, 1 rater, the reliability would be here, let's say, hypothetically. If we have 5 cases, 1 rater, it would be here. And then if we had 10 cases, 1 rater, it might go up here. And eventually what you have is this will start to happen. It'll plateau eventually. You never get to perfectly 1, right? So now that's 1 rater with black. Red, we're going to say 2 raters. When you have 2 raters, you start to have maybe a little bit better. Maybe a little bit better. Maybe a little bit better. So it looks something like that. And if you have 3 raters, then it's a little bit better. A little bit better, and it's like that. And the point is that the gain between 1, 2, and 3 is much smaller than it is between 1, 2, 3, and 4, 5 stations. So as you increase stations, the reliability goes up faster than you do number of raters per station. So where this is relevant is if you have limited resources. If you only have in your home setting 5 colleges, for example, sometimes have limited. So they say, I only have 5 raters, what should I do? Should I have 1 case with, or better yet, I have 6 raters. Should I have 2 cases per rater or per station? Should I have 3 cases or 3, let me say that again. I have 6 raters. If you have 6 raters, Should I put all 6 raters in one station, 2 raters per station, 3 raters per station? What should I do? And the answer is always, always, always increase stations over number of raters per station. Always. Because the number of stations is a bigger source of error. The number of stations is a bigger source of error than raters are every time, hands down. Source of error, the number one source of error is context specificity. To deal with that, you increase the number of stations. And number 2, there's some others, but rater training or rater error falls below context specificity. So when resources are limited, you always increase stations as opposed to number of raters per station because of this formula.
So if a person goes through the 7 stations and they make a drug error and kill someone, that's only in one component of their overall assessment. So they could end up competent and safe overall, but killed someone.
Mm-hmm.
So that is a person that maybe isn't. I don't know. How does that work?
Okay, you raise an excellent point, and that's going to be our discussion later about critical errors. And so what you raised there is 2 things: how to deal with critical errors and outcome over process. So what you've said, and it's very common, is that you are very concerned about, I shouldn't put this on you, people are very concerned about outcome. And we said earlier, intentionally, process is a big part of this. Outcome is only one part of it. Now, emotionally, it's a big part. Statistically, it's not a big part. So the whole point of the assessment process is to predict future clinical performance. That's what we're interested in. Not the outcome of this patient. That is secondary. That's not common, right? That's not how people think about this, right? Your goal is about, and I'll get to you in a second. So the goal again, and I want to make this very, very clear, it's about predicting future clinical performance. If you allow, and I'm going to come back to this later because it's so important, if you allow one behavior to assign a score, then the ability to predict future clinical performance is washed away. And I'm going to come back to that later. So again, it's not the outcome of your patient in your scenario, it's how well can you predict future clinical performance. That's what you're doing. And that's very hard to say, but the patient died, and he put epi in his eye. Like, you know, and you're like, there's no way I'm.
The fidelity of the simulation and how reliant that person is on their environmental cues, because would their partner have caught that critical error in real life performance, and also would they not have been able to reference something in order to make sure that their drug dose was correct, Broslo-tape, ALS, PCS, that sort of thing.
So that comes into the authenticity of the case and how we develop it. It's true that if you eliminate a Broslo tape and they would have that, then it's not as authentic. But you may intentionally eliminate the Broslo tape because one of your objectives is to determine whether or not they know the drugs and the formulas and whatever. So there's a balancing act that goes on there, but you're 100% right that that threatens the ability to predict future clinical performance a little bit. Yeah. And that's the goal. That's the number one goal. Is anybody here, I mean, lots of raters in here that have been around for a long time. Anybody ever failed a student, a candidate, whatever, for sharp safety? I have. So I've failed somebody in the paramedic program, I hate to admit it, for sharp safety. And yes, they did something wrong in that case at that time, but that is not a good predictor of future clinical performance. And that is one of the motivators for us transitioning to this process, because something like that is insane to do that. You know, it's not a predictor. Is you going to rate another video? This is the exact same case that you observed the first time, just a different candidate. But this time, I'd like you to put in practice a little bit some of the things we've already talked about. So for example, have a look now at the dimensions first. Okay, just read through these dimensions, get a sense of them and what they mean. If you didn't do that the first time, just do that now. Another thing you should do is maybe look at the rating labels. I'll just give you a couple minutes just to read through the dimensions most importantly, okay? On the top of your GRS there, just put that this is video 2. If we have time, we'll go through the scores and have a look at it. A couple things I want to point out about the rating tools here. So let's just look at history gathering, for example. So it describes what it is, overall ability to effectively and thoroughly gather appropriate history, tells you what it is. It's organized, it's appropriately structured. Okay, so it's appropriately structured, time and focused according to the clinical situation and level of urgency. What that means is not everything has to be asked, right? And if you can imagine a checklist that's created in advance and said, these are all the things that are on the that are part of the history gathering. Did they get them all? That's it's irrelevant. Is it appropriate? Is it prioritized? Is it focused appropriately? Is it gathered at the right times and so on? What you saw in the first video was a guy who probably gets most of the information that's available, but it's all over the place. It's late, it's well after decisions are made, so he gathers it, and he would have on a checklist got scores on all of it, but it wasn't organized, it wasn't properly timed, and it wasn't structured given the context. And that's one of the features of this particular part here. The other part is also refers to demonstrated ability to include a consideration for differential diagnosis. It would be very, very difficult to create, especially a generic tool, but you could probably do this with a checklist, create all the different differentials to consider and which ones should be considered. You could probably list that out. But the context directs that to some extent. The age of the patient, their history, etc., all that stuff drives certain differentials over others. And so the degree to which they consider that is how history gathering is scored, right? So you can see how there's flaws in a checklist type approach given the craziness of context, right? So all of these have reference to those types of things. Working differential diagnosis, timing, context is all indicated in there. As you're going through and watching this video, what some people have done, because it's so hard to remember all these things, I'm not suggesting you don't have to do this, it's totally up to you. But what some people do is when they see certain elements that are relevant to a dimension, they just jot it down. They just jot it down, they go, asked about meds, got a history, forgot allergies, whatever. They just jot that stuff down under the categories, under the spaces there, or on a separate piece of paper. They jot them down, and then they come back, and when they think of each dimension independently, they just focus in on their notes, and then try to come up with a decision based on the structure we give you, which was go back up to the rating labels and so on. Now, somebody asked earlier about weights. If there's 7 behaviors that I identify, how do I give weights to those? That cannot be prescribed. That's totally you, and I trust your judgment in being able to determine which behaviors and questions are more relevant than others. So I think, and I could be wrong on this, but I think the implementation group decided that these would not be shared with the candidates, right? And that's important because if you put, my God, that's terrible, or this guy's crazy, whatever, and they see that, then it's, that's problematic. So I don't think that they're going to see this, so you can probably feel free to jot down what you want. But if they were to, so I don't know if there's any key words, but if they were to see it, or to be consistent in the writing, to your point, what we often encourage people to do when they document there is to make reference to one of the rating labels definitions, right? So for example, if their performance was occasionally to standard, I would put, the fact that they did this, and this, but not that and that tells me that the performance was, at times to standard, but at other times it wasn't. So we make reference back to the rating label definitions, yeah. And in fact, if you could use the language there, it strengthens the defense of the score. So if it gets to a point, now colleges deal with this all the time, these things are appealed all the time. And we encourage the raters to document in that way so that it's very evident why they selected whatever score they did, high or low. If the people here never see it, and it might be a good practice for you to do that, but if the candidates never see these, then that's probably less relevant, but it might be a good cognitive practice. Okay? So again, feel free to make notes on this. You don't have to. That's just a suggestion. Some people rather just sit back, absorb, watch, and go from there. But that oftentimes can be very difficult when you have to consider 7 dimensions at the same time. So often a little bit of note-taking is helpful. Okay, so let's give this a shot. Another video, exact same case that you saw before, same features, same everything, just different person. Okay?
We took this thing and this transfer.
Why does he
guys,
have
we need
no
to
idea
calm
what
down a
she's
little bit. I
doing?
need to hear a story from one person who's in charge. I can't believe that she asked me. That's why she's No, it's your fault because you shouldn't have taken the transfer. No,
Okay, so he's moaning. He doesn't have an
Whatever.
idea.
He was
breathing.
stable. He was walking. He was laughing. Why wouldn't you take him?
Okay, so guys, why were you called in the first place?
We were at a nursing home. We took
Okay,
him from
he's
a
pretty
nursing home.
tacky. Okay.
He's tacky.
Sir, can you open your eyes?
What does tacky mean?
Can you?
I don't know.
Is he opening his eyes at all when I do that?
I don't know.
Do you have any complaints before?
No, he was sleeping. He was fine. All of a sudden, he's like this.
Okay. Is this oxygen on right
Yeah,
here?
yeah.
Okay. Are you guys able to insert a nasal airway?
The hell's a nasal airway?
You've never heard of that before? Can you pass me that bag up here, please? Do you guys know how to monitor on a cardiac monitor
I
at all?
have no idea what you're talking
Okay,
about.
I saw that you were checking his blood sugar there. Did you get
Yeah.
anything back
It
on
was
a blood sugar?
8.8.
Okay, so blood sugar's good. Sir, what's his name?
Jim.
Jim, can you open your eyes?
Oh my god, I can't.
Jim,
believe
open your
It's
eyes.
your fault, you know. How is this my fault? You drive and you watch the patient and you can't
Enough, okay? There's more important things right now. I don't want to hear the two of you arguing. Sit down right there.
No, you can stay there. I'll stay with you.
Okay, well then what do you want?
Girls, I know. Tell me about something. What do you want me to talk about?
I don't know. What did you say on that radio?
Probably wants to know why we're stopped and why we're pulled over. To change the windshield washer fluid. This isn't a buy that.
Oh, just do it.
Fine.
Dispatch Eagle 1, 2, 3, 4, clinical.
Oh my god, I can't believe this happened.
Washer fluid. That's gonna buy us 5 minutes.
Well, that's better than nothing.
Girls, let's get a set of vitals. Are you able to do a set of vitals? A blood
Sure.
pressure,
What do you
heart
want
rate,
me to
that sort
do?
of thing? Can you get me a blood pressure,
Yeah, I'll leave it
please?
here.
Can you get me a heart rate as well? I feel that he has no radial pulses, so let's get the blood pressure first. Do you guys have a sat monitor at all?
I don't know.
You don't know what that is?
You have
okay,
stuff,
fair
don't
enough. Do you have access to all of his medical information, his past medical history,
She
his
has a
medications,
list.
his allergies?
Okay, I did his
has
blood
the list.
pressure. His blood pressure is 48/68.
Oh,
Who got
goodness.
the list of medications?
You have
Can I
it.
get a,
No, I gave it to you.
Oh my god, I left it at the nursing home because you were talking so much. You should have figured it out and took it.
Patient, you're supposed
Okay,
to
since
bring
his blood
medical
pressure's girls, can we watch our voices, please? This guy's in a medical emergency, alright?
Well, that's why
We're gonna
you're
lie him
here.
down because his blood pressure is so poor. We're gonna get a nasal airway in because that would be ideal. And you said that you do have access to his medical information? or
I
you
talked to the
don't?
nurse. I know what's
Okay,
wrong
and
with
what's
him.
going on?
He has Alzheimer's.
Can
He
you
has
check-
coronary artery disease. He's
Okay.
had 2 MIs.
Where's the
Stroke.
nasals in here?
Probably up here somewhere.
2 MI, stroke.
Stroke, diabetic, Alzheimer's, dementia,
Okay.
hypertension, high cholesterol.
You guys aren't familiar with this at all?
He has my entire list of medical
Okay.
problems.
Yeah,
and
he's old.
talking so old.
We do
You
this
guys
all
know
the
how to hook up this
time.
call?
They don't have a medical
My dear,
condition
can you
like
do me a
this.
favor? There's cables in the side. There's black cables in the side. You need to hook them up to his chest here. Okay, so I'm gonna lubricate this.
Oh my god, I can't believe this is happening. I'm gonna fail school. I'm not gonna keep
Assuming
my
that
job.
you
You
the
like,
nasal
you
airway.
deserve to fail, honestly.
124, what's going on? Could you please confirm that you're still transporting? Please confirm.
What do you want me to tell this
Can you
guy,
tell
Billy?
them that you're with a paramedic right now?
No,
You're gonna have to
no.
reroute.
They're
to the
gonna freak
hospital.
out.
That's okay. You're gonna have to reroute.
We don't go to
the
We don't go to the
hospital.
hospital.
Okay, well, unfortunately, you're gonna have a change of plans today. We're gonna wait for a transport unit and go on our own, okay?
So you want me to tell him that you're
Is
here?
is his color look good to me right now?
I don't know.
1, 2, 3, 4.
Like,
We
does
have
he look-
paramedic at the back of the truck.
I have nobody to talk to, eh?
No.
No.
Give you an
Okay,
update
so he's
shortly.
he's in intact. Okay, that's not ideal.
Oh my god, I
Can you
can't
get
believe
the
this
defib
happened.
cables ready out of there just in case? Okay, so this guy's in a heart rhythm that's quite irregular. Does he have any heart history at all? You said he's had 2 MIs in the past?
Yep.
Well, at least his
Okay,
heart's
any
beating.
heart
That's good,
surgery
right?
that we're aware of?
I don't know.
No. Okay. Jim, that's his name, right? Jim? Yep. Jim, open your eyes for me.
I can't believe this is happening.
Okay, what's the phone that I have here?
Maybe if you paid more attention when we were getting a report from the nurse, we wouldn't have had to take this patient.
Maybe if you
Instead
paid
of
more
you flirting with the nurse.
Maybe if you paid more attention to this patient, this wouldn't happen.
So why was he coming out of the hospital today?
He wasn't in the nursing home.
Oh, so you're just going nursing home to nursing home?
Yep.
Okay, fair enough. Yeah, do you have a list of his medications as well?
No, she forgot the list.
Oh, goodness.
I know the
Ross.
medications though.
Yeah. Okay, what you can do for me then? Come right here.
What?
I need you to hold. Do you know how to do a jaw thrust?
No!
Okay, I'm gonna teach you right now. See underneath the
She
jaw
doesn't
here?
know any of this
Pull up
kind
on
of
his
stuff.
jaw.
Pull up, that's it?
Yeah.
Okay.
Let's check for a pulse and make sure he's got one.
Oh my god.
Okay, where are those defib cables?
They're on already.
Okay, great. I need you to stand clear.
Okay.
We're gonna
So he's not
analyze.
holding his head anymore.
No, not right now.
I can't believe
It
this
looks like right now
happened.
he's not got a pulse at all, okay?
So that means
So what we're gonna
So
do
he's
is
dead.
we're gonna defibrillate
Great.
him. Stand
Good job,
clear,
you
stand
killed
clear.
him.
Move your foot. Analyze.
How many have you killed now?
None.
Shocking.
Including this one, you mean like 5?
Okay, do you know how to do CPR?
Sure.
Hands on the
Okay,
chest
I
right
can do
here.
it. You don't have to
Okay,
pull
let's
my
go.
arms.
That's because you're incompetent. You have no idea what you're doing.
Okay, my goodness. Can you watch your attitude, please?
Okay. She started it.
Okay, you need to get the BVM for me. Do you know how to bag somebody?
Me?
Yeah, you.
No, definitely not.
Okay.
She's not trained in anything. She just drives. That's all her.
Okay,
Training
can you
it.
speed up your CPR a little bit and let me know when you're at 30, please? Get rid of this for me and switch seats with me, please.
You don't actually have a seat, so I'm not switching anything with you. I'm just standing.
Let me know when you're at 30.
30.
Okay, 2 breaths. Keep your hands on his chest. Compliance is good. Air is going in nice and well. 30 again. So girls, what the plan is right now, because his heart has stopped beating on his own, he stopped breathing on his own, what we're going to do is we're going to go through the same protocol we would normally as a paramedic to try to get him back to life, okay?
30.
What's going on? Are you transporting? Please confirm that you're still transporting.
Okay,
Okay, talk to them.
and tell
Well,
them what
you're
you're
gonna
gonna
that out.
You're going to have to tell him that you're delayed. You know, you run into some sort of problem, there's a paramedic on scene. Let me know when you're at 30, okay?
Do I tell them that our patient's dead?
Tell them.
You can tell him that he's being assessed by a paramedic if that's what you're comfortable
Okay,
with.
that's
We have
better.
30.
Okay, good. Dispatch vehicle 123
Stand clear, please.
pulled over patients being assessed by a paramedic.
Finally, you can do something right.
Can you
Whose
update
fault
the
is this?
patient's
Well, obviously it's the nursing home's fault.
No, it's obviously your fault. He was alive, talking, walking,
Well, so how would we know?
joking.
Yeah, walking because you didn't want to lift him because you're a bad old back.
Are those cables not on or something? Is there a reason why this isn't analyzing?
Try again.
So these
Why does it
pads.
keep doing that?
Try fidgeting.
Just shock him.
Stand clear.
Yeah, it's analyzed now. Okay,
Whatever
stand
you
clear.
did.
Don't touch the stretcher, okay?
You did something right for once in your life.
Well, at least I know how to work it. You just stand there and hold a radio and the car keys.
Actually,
Okay, guys, I'm shocking. Stand clear.
Please round two. What's going on?
Second shock. Okay, back on the chest.
Oh my god.
Okay, you
Are
want
you,
to-
are you able to do CPR as well?
No, I have
Yeah,
no
right.
idea. No.
I haven't learned to CPR on my cat.
Have you ever bagged anybody before?
Sure. Not in
Is
real
that a
life.
yes or no?
Not in real life.
Okay.
But I've
Let me
trained
know
in all
when,
of
let
it.
me know when you're at 30. Let me know if you're getting tired, okay? You're gonna have to go a little bit faster than that.
Yeah, I have
A little
no idea
slower.
What you're doing.
There you go.
A little faster, a little slower.
30.
You have no idea what you're doing, Natalie.
Just go away.
Okay, wait till I do the 2 breaths before you get back on the chest. Go
See?
ahead.
Who do you know what you're doing?
Go ahead. Okay, my dear, if you're not going to be helpful, then you can have a seat in the front.
For this video, situation awareness, how many people gave her a 1? How many people gave her a 1 for situation awareness? Nobody? 2? 3? 4? 5? 1, 2, 3, 4, 5, 6, 7, 8, 9? 6? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. 7? Okay. History gathering. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 6. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 7. Okay. Patient assessments. 1, 2, 3, 4, 5, and 7. 1, 2. Okay. So, what do you think? Okay. Look at how tight, within a point, you are on a very subjective rating tool. With just a little bit of coaching. It's all I've given you is just a little bit of coaching. And I've intentionally left out one big piece that we're going to do next. Those of you who were in this range, so again, what's missing from here is the frame of reference and the case details, because I gave you nothing. I just told you what the case is. What's missing from that, and that's keeping you still a little bit far apart, but as I give you that information, you'll see this will get even tighter. So what you're seeing here is you can sense that people have slightly different views about things. And what we're trying to do by having the conversation is to try to get us a little closer. Let's work out this issue of the monitor thing and agree on what we're going to do with it. And then this will tighten a bit, for example. Like if we were to watch the next one and we agreed right now, I mean, we said, okay, yeah, we're not going to let that affect our scoring, then that would tighten us a bit. The people up here would probably come down a bit. The people here would move up, whatever. So in the dry run piece, if you're part of that, I want you to have these conversations. Right? You'll score it, come up with it on your own, and then discuss them. Because that whole dry run piece is a bit of a calibration process. You're there to calibrate each other to some extent to get there. Now, in the offering that we're going to do, we're not going to let you talk because we want to calculate inter-rater reliability and we don't want to influence that too much, right? So, but in the dry run piece, you want to have these conversations, and ahead of the case, before they start, you want to try to think of all these hypotheticals, have conversations about them and how you're going to deal with them. And the other thing I want you to think about is you don't have to all be at 5 or all be at 6. This is fine. This is a little bit concerning. I mean, we have to try to fix that. But it's only happening in 1 dimension, maybe 2 dimension. That's not that bad. Don't think that you have to be all sitting perfectly on one row here. It's not the case. The calibration process, you really should score them independently and then talk about it. Because the whole point is to calibrate you. But when we're trying to really calculate inter-rater reliability, the idea is to have you guys apart and not discuss them and that sort of thing. Yeah.
Technically, we will be apart.
Yep. And that's something, to be honest, now that I think about it, that'll be something that we'll have to discuss with the research group and the implementation group to decide whether or not we're going to allow you to calibrate over time. That's because it has implications. It's good for the implementation, bad for the research, and so we just have to figure that out. But we'll work that out and give you some instructions on that ahead of time. Okay, so this is not bad. I mean, we're a little bit off here, but generally over there, you shouldn't expect that we should be absolutely, everybody's exactly the same way. That's why we're including multiple stations. Otherwise, if we were perfect every single time, we wouldn't need that. That's one of the reasons why we include multiple stations. The reason why we're doing 2 raters, by the way, in the initial offering is because we want to demonstrate evaluate what the inter-rater reliability is. If it's high enough, then we can say in the future, we don't need 2 raters per station. If it's low enough, then we have to come back here and say, okay, what do we have to do to fix that if it's too low? But if it's high, then you've got the defensibility going forward to say 1 rater per station is fine. Because it's a cost thing, right? So we want to be able to defend it, that's all. And in the initial study, we demonstrated that the inter-rater reliability was good enough, and that's what we use as defense for only using 1 rater per station every time. We say they're redundant, basically. Okay, rater error. I'm going to come back to this page eventually when we do another one. Now let's talk about rater error. So types of rater error. Anybody have any ideas of what some types of rater error might be?
Your own judgments.
What's that?
Your own judgments on the definitions.
Okay, I'll use that. On judgments, yep. Anything else? Any other types of problems that could be induced by raters?
Distractions.
Distractions, okay, so I'll say overloaded. Anything else?
if the raters communicate after, is one more perhaps timid, one more strong-minded than the other?
Right, we'll say calibration. Yeah,
Failure to follow the same standard of care.
okay, we call that frame of reference. Differences, we'll say. Yep. Anything else? I'll add a couple more. One is called halo. I'll define this. Leniency versus stringency. We mentioned that. Another one is called restriction of range. Another one is contrast effects. We already talked about this one. We also talked about performance dimension differences, and also frame of reference we've already talked about. Let me just make sure I got them all. That's good enough. Oh, I'll add two more. Another one is something we call isms. I'll describe that. And the last one is radar cognition. Okay, so halo basically is, again, we've talked about this before, is taking your general overall impression and going 3, 3, 3, 3, 3, 3, 3, 3, 3. Okay? When people do that, they're not, it's sort of like a big halo kind of thing. When people do that, they are not differentiating between dimensions. The way we identify that is high interdimension correlations. When we see that, we instantly start to wonder whether or not they're differentiating. Now, a caution. The caution is, the reality is that student who just went through there could be all 5s. And if that's the case, then they're all 5s. That's okay. It's just that candidate after candidate after candidate after candidate after candidate, we start to see that, then it raises a flag for us in that, maybe the radar's not doing what they should be. I only mention this because not to force you into all 5s or force you to do different scores, but just to remind you of the importance of treating each dimension on its own. You can have really good communication but terrible decision making, right? You can have really great resource utilization but terrible situation awareness and so on. So treat them independently. So that's that one. Frame of reference differences, we're going to give you what the frame of reference is, and that should correct that. And that will come up in radar cognition as well. So we're going to tell you what frame of reference to use. She shocked right away. She defibrillated right away. We know that to be correct, and so that's because we all share the same frame of reference on that. But you can see there's lots of other things that we might not share the same frame of reference, and the goal of the content people is to give us the shared content, or the shared frame of reference, shared standard. Okay, so we'll come back to that. Own judgments we'll talk about under radar cognition. Overloaded is definitely a problem, so the note-taking that I suggested to you is a way of helping with that overload. It's really tough for you to hold 7 dimensions in your head and to consider them all simultaneously. So just for now, until you get really good at it, maybe some note-taking should be able to deal with some of that. Calibration.
And yet does potentially cause the distraction side, and this is the no CPR,
Exactly.
watching the other piece or making the note.
Exactly.
So,
You just have to find that balance, yeah. Find out what works.
How about the time of the day, Walter?
Yes.
Maybe more sharp at the end of the day versus the end of the day.
is that the radar or the?
The radar.
That's called drift, and that's a true thing. That absolutely happens.
Yeah.
And other than try to keep, we're going to limit the day as much as possible, but you're right, we can go on for long periods of time, and that can be really difficult. We find after about 3 rounds, the 4th round is lucky for the people that are coming through, or unlucky for the people that are coming through.
Also, maybe this is accounting for one of the other ones, but I think one of the challenges in this industry has often been hierarchy, so to speak, right? So you have one rater that's a physician, one rater that's a medic.
Yeah.
8 from this person means more than 8 from this person.
Yeah.
How do you overcome that?
Yeah, so for us, the way we interpret it, everyone's score is the same.
It is what it is.
It is what it is, yeah. We don't care. In fact, we wanted to compare physicians to you guys, and I think you guys would actually do better because your frame of reference is more similar than theirs. Theirs is much more all over the place, and yours is probably closer to the students that are going through, the candidates going through, and more alike. But they didn't want to do that. Leniency versus stringency is again not using a 1 or not using a 7. Okay. sorry, that's restriction of range. Leniency is if you're putting everybody up in the top scores. Stringency is putting everybody down the low scores. Nobody can get over 5 on my watch. You know, that kind of stringency, right? Or, well, you know, no one's that bad. You know, like we don't want to be tough here. Like everyone's okay. You know, they all graduated from somewhere. They should be fine. So leniency, restriction of range is not using the 1 or the 7 or the 2 or the 6 or whatever, and always staying at 5 or 4 or 3 or something like that. So again, your goal is to differentiate between candidates. So if they're a 1 or a 2, then they're a 1 or a 2. So let's put them down there. Contrast effects is what we talked about earlier in terms of allowing the performance that you just watched to influence the next one. As much as you humanly can do, you try not to let that happen, but it is human to have that happen, and so you just try to control it as much as you can. I'm just raising these here purely for awareness, that you are suddenly perhaps a little bit more aware that these things could happen. Performance dimension, we already talked about, making sure that we're all in the same, using all the same definitions for the dimensions. Isms are things like ageism, sexism, racism, all those things that can affect your observation and your scoring of these people. Another one sometimes is people who are extremely socially awkward. Might be clinically strong, but so socially awkward that it's painful to watch and go through. And so those people get scored harder sometimes because we can't look past their social awkwardness and score their procedural skills on their own. So that, again, only to make you aware that these things exist and for you to be careful about them. The radar cognition piece, we talked about drift already. The radar cognition piece is 2 things. One we already talked about in terms of being overloaded. The other one is the performance theories, and I talked to somebody about this at the break. The performance theories are what we hold as most important. You heard different things here when we talked about it. Some people emphasized, you know, the fact that no CPR was done, and they hold that as a very strong value, or as a performance characteristic. Some people, you know, the troubleshooting. So, you know, you can go on and all the different reasons why, or the things that are most important to people. And this is very natural for when you're observing somebody for you to resort back to those natural existing performance theories that you have in your head. And the only way we could deal with that, because we'll never eliminate that totally, the only way we can deal with that is to try to give you a little bit of a frame of reference to work with, right? So that you can shape that a little bit, so that, again, we can all look at it the same, we can look at the performance the exact same way every single time. So that's the piece that we'll give you next. Okay, what I've given you here is just a model. This case isn't going to be used in your setting, but it is a template that you'll see again. And the content development group, feel free to chime in anywhere here if there's something that I say that's wrong. So this is a rough template of what you're expected to see. On the first page is a laid out description of the entire case. Call information, patient presentation, incident history details, health history, vital signs, physical exam, case progression, treatment considerations, and such. There might be a couple of different headings in the one that you see, but it's very similar to this. And so this is to give you as much of a picture of the case as possible. Because you weren't the one to develop it, we need to be as explicit as possible about what you're going to carry out. Now, carrying out the case is part your responsibility, because you'll be there, part the responsibility of the patients, of the partner, of the bystanders, all that stuff. So everyone gets coached to some extent using this case description. So everyone sees this piece for the most part and tries to create a case that just unfolds like it should, and so on. The next piece on the back of that page and the next page are what we would call performance expectations or the frame of reference. So for each dimension, someone's taken the time to indicate what should happen or what are some key points relevant to each dimension. This is a lot of work for those case developers that did the work. To come up with all of this is a lot of work, and sometimes it can't be perfect. So you might have to make some adjustments. But for the most part, they've tried to think of everything and tried to put everything in there that is necessary to give you a frame of reference. This is the last piece. So there's 2 things that I've given you. I've given you the global rating scale. We've outlined the whole logic behind the 7 stations, multiple raters, multiple contexts. You've seen that many different reasons why that's relevant. Then I've given you this. This is the global rating scale. This is your performance dimension piece. And now this is your frame of reference piece. And we've talked about some of the common rater errors. These two things have to go together. The very first case you watched, we didn't give you this. And you were thinking, you just thought whatever you thought and went through your whole process. And for this process to work better, to get us aligned even further, these things have to go together. If you try to apply a case with this, without having this piece, then it's not as strong as having the two together, okay? So that page has all the performance expectations laid out there. And then there's some information regarding the case stem, what the student or the candidate would read before they come into the station. And then it has a bunch of just stations set up and simulation requirements and such for you to deliver this. It's even important to know what the student or the candidate sees coming in, because you need to know what they are thinking in terms of what they've been told. So reading that piece is important. Reading the case as it unfolds and then the performance expectations is all part of giving you the picture you need. This is one of the reasons why we don't have you moving stations. We give you one station, it's a lot of information, think it through, work it through, and then right away. Okay, so this is the last piece. So we're going to watch this video, but I got to give you some time to read through this, okay? So take a few minutes to read through this as much as you can, and then we'll come back together and watch this video and try and score it, okay?
I think we are good.
You guys are good?
Yeah.
Okay. So let's go through it. Hey guys. What's going on?
Not too much, how are you?
Not bad. What's going on with this guy?
So, 35-year-old male. He took an overdose on amitriptyline, clonazepam, and Tylenol 3, and a whole bunch of alcohol.
Yeah.
His wife found him, but we really have no idea when it was that he took the pills. He's been breathing spontaneously with us, but not at a very fast rate. We're having a really tough time bagging him here.
Stats aren't all that great either.
They certainly aren't. They haven't been. We're having a really tough time bagging him. He has vomited once,
You got an IV in?
but it's been a while.
Can you open up that IV for me? So you're having a difficult time validating, you said, okay?
Yeah, tough to squeeze the bag. I'm not seeing any chest rise.
Okay, can you guys put him into your sternal natural pill plus an adjunctive and use a two-handed seal and let me know if that improves anything. In the meantime, I'll get set up to intubate this guy since it looks like he's quite decreased level of consciousness.
Okay, so
a good respiratory effort. So I'll get some stuff set up. In the meantime, I'll try and optimize some of the LS techniques to see if we can get them working a little bit better.
okay, so Maria, I'll hold the seal and you want to squeeze the bag. So we now have an OPA in. We're doing a two-handed BBM seal. We have a pillow in to support ear to sternal notch.
Okay, that's great. Do you guys have nasal airways handy?
Yes, we do. They're here on the side.
That doesn't seem to do the trick. Then we'll toss in a nasal airway. Let me know if that's getting any better with that.
Do you know his SATs have not improved, and is compliance still as bad as it ever was, Maria?
Yeah, still bad as it ever was.
Okay, we're going to stop ventilating for a second then, Justin, and we'll put in a nasal.
You guys getting a CO2 when you were ventilating him?
No reading.
Did you hear any breath sounds with him earlier?
We did. We heard clear air entry when we listened earlier.
Like good air entry?
Very
So the bottom thing? Or?
I would say it was decreased.
Alright.
Very little audible, but we didn't hear any sound, like adventitious sounds when we listened.
Where do you have your oxygen running at?
We've got it at 15 liters per minute.
Okay, let's bump it up to 25.
Okay.
And if you can, when you get a second, let's take some nasal prongs. Let's put those under the BBM mask. And see if we can improve his oxygenation, get his stats up a little bit as well.
Okay, so he currently has a nasal airway, or NPA, in his right nostril only. It doesn't seem to be improving anything, so I'll get that nasal cannula on for you, so we'll just stop for a sec.
And I'm just going to steam from behind you here. And do a quick assessment as well. Can I scooch behind you just a little bit?
Okay, so we can resume ventilating. So he now has one nasal airway, an oral airway, nasal cannula, two-handed seal.
Now we're running both of those. So run the nasal prongs at 50 liters as well for me if you could. Let's really try and improve his oxygenation. How's his code been with you guys?
Not very good. It's as found. So
He's getting more attack, yeah?
Yeah, it looks like he's just gotten worse there.
He's bagging for a couple of things for me.
Looks like his pressures, his rest rate seems to be dropping there. The spontaneous stats coming down.
Okay, cool. Can I ask you please? Yeah. Andrea, can you do that one-handed for me?
Yep.
Maria, I'm going to actually run through this checklist, alright? Can you start here? Read all those items off to me if you could, please.
Monitoring ECG.
Check.
SpO2. Check. BP cuff.
Check.
Waveform ECT CO2.
Filters on. Yep.
Positioning ear to sternal arch.
Check.
Head elevated.
Let's set this up a little bit. Put this at maybe 45 degrees. See if we can improve ventilation. Check.
Ramp if obese.
Not required.
Collar open.
Not required.
Pre-oxygenation.
In progress.
NRP. Consider nasal prong.
Go on.
Bag mask.
Check.
And visualize airway.
So I don't see any signs of difficulty. He doesn't have a beard, he doesn't have a short neck, there's no obvious signs predictive of difficulty. Check. And then this category here.
Okay. Intubation suction.
Check.
Laryngoscope.
Check.
Oxygen submission.
Yep, 2 sources running.
PPE.
Check.
ETT checked.
ETT is checked, I've got a 6.
Syringe.
Check.
Boogie.
Yep, bougie check.
EDM.
Check.
OTA.
In place, yep.
NPA times 2.
Check.
Circuit.
Yep, there's a sample.
Tube restraint.
Check.
IV access.
Yep, we've got 1 line in.
Okay.
That category.
Role assigned intubator.
So that'll be me.
Assistant.
Maybe you're gonna assist.
Okay. C-spine.
Not required.
Hemodynamics.
Yep, you're gonna be watching the monitor for me.
Okay.
So I should let you know if this number goes down, and particularly if this number goes down.
Okay. Plan verbalized.
Okay.
Alternate airway checked.
So I'm going to verbalize the plan really quick. I'm going to have a first look. If I can't review, we're going to pull it and reoxygenate it by the mask, and we'll prepare for another attempt.
Okay. Crate kick available.
Yep. Crate kit is available. Should the need arise.
Push drugs, pre-intubation facilitation drugs.
Not required. Patient's comatose.
Post-intubation drugs.
And we have those handy. Okay, so I'm going to swap places with you. Lower this down a little bit. Keep the name of Congress running. Last one, 15 to 25 years old.
Okay.
There is out. Now let's have a look and see what we can see. What's that heart rate at?
113.
Good, sounds slower.
97. 91. 81.
Copy. Sets.
82.
I've got a suboptimal view. I've got a partial view. Let me try and thread the bougie in.
Heart rate is at 40.
Copy.
Stats at 74.
So I'm not sure if that's in. Let's pass that too. We're going to have a real quick listen and see if this is in place. I think I saw it go through, but I didn't have a great view. Got it. Could use a little bit of lube, but it's alright. Okay, can you pull that out for me? Breathing. Let's plug that in.
Okay.
Wait, can you have a listen for me and let me know what you hear? Sure. How's it feel to go like that?
Very poor.
You're not seeing
I'm not seeing any
CO2?
chest rise and fall. I'm not seeing any waveform on the CO2.
Okay, I'll go through and we'll pull that out. So we're going to pull that out.
Okay. I'm not hearing much.
Okay. So let's take that out. Let's reoxygenate the bag to our mask.
Is it removed?
Second attempt.
Reoxygenating.
Maria, can you set this up for me and get that ready, just in case we need that?
Just be aware the end came off of your tube.
Got it. So patient's quite bradycardic. Stats are quite poor. IV running wide open. Let's try and see if we can get any oxygenation going on. As a temporizing measure, we're going to get some atropine, so you can get his heart rate up a little bit. So I'm going to toss in 0.5 of atropine.
Just an update. Compliance remains extremely poor. No chest rise and fall. Just as difficult as ever.
Copy. 0.5 of atropine's in. You've got that checked and prepped?
Yep.
Okay, so plan B I'm going to visualize. I'm going to try another attempt to oral intubation. If I can't get a view, you're going to pop that in really quick for me, okay? So we'll swap places. We'll take the air out. Just find that moving for me. Always get off the floor. Epiglottis. Got a good view. Slip it.
Where's the 10 cc?
Get in there. Ready, Maria? Come on in here.
Would you like me to?
Hey, it's in. Right, slide the tube over that corner. And we'll try this. So still severe bradycardia. Can you find that preload syringe that's kicking around? Maria? It should be on the bench behind you there.
So bradycardia worse. You're desatting even further.
And give me a second, put up the cup. And let's see if we can get that in.
Extremely poor compliance. Having to squeeze the bag really hard. Don't see any chest rise and fall.
Another 0.5 of atropine's in, copy, I heard that. Down that's CO2.
No,
so let's go ahead and assume that's esophageal.
Okay.
Maria, as soon as I pull this out, I want you to pop in that airway panel, okay? Okay, that's the plate, we'll pop that out. While we're doing that, I'm going to get emergency surgical airway ready. If you can't get that in, let me know right away. Or if that doesn't work, and we'll go to surgical if that doesn't work.
Too well?
Are you able to place it at all?
It's not going down.
Not going at all?
No.
Okay, pull it out. Easy one back on, please. I'll take the critical forward membrane, and we're going to go surgical array. We'll dart that in.
Okay, and the scenario's over.
Okay, I'll let you continue scoring there, but just I want to make sure we get to two very important issues. If we have time, we'll take up these scores. Hopefully we will. So there's two things that come up. Weighting and critical errors. So let's talk about weighting first, and we already alluded to this a little bit. Some things just stick in people, right?
The teeth.
That teeth thing, I can't look past that. I just, some people, they just can't look past it. And that will move them down the scale, drastically. Other people will say, yeah, that sucked. That was not good. That was one thing, but there were lots of other things that were there, and we need to consider the whole picture here. So I'm going to show it to you this way. If, let's say, we'll say procedural skills. Let's say in procedural skills, there's a bunch of behaviors that happen to be present in this or any other scenario, it doesn't matter. But let's say there's 10 procedural skills that happen, 10 things that would fall into that category. If we saw 10 really bad ones, 9 really bad ones, bad, good, would we allow this really good one to speak for the other 9?
No.
Of course not, right? Because if our goal is to predict future clinical performance, that doesn't make any sense. If we observe all of these things, then we would want, all of these things together is a much better predictor of future clinical performance than just this one, right? Makes perfect sense. So let me do this again. And I've set you up in a way here. I admit it. Good, bad. Would you let this one speak for the other 9? The answer is no. Right? Logically, the answer is no. But to the question that we had earlier but the patient died. But there were 9 other things that were good, but the patient died. When you do that, when you say there's 9 things that were there, but this one is the one I care about, you remove these other 9. And your ability to predict future clinical performance is flawed. Because now you're predicting performance on that behavior, not these behaviors. Go ahead.
But what if it's multiple components? of that
509,
particular skill.
409.
Yeah. Right, like airway positioning.
Yeah.
teeth.
Good, bad, good, good,
Right.
bad, good, good. Something like that. Then you decide how you want to weight those behaviors. And I'm not suggesting, by the way, that you give this 10% of the vote, 10% of the vote. I'm not suggesting that at all. I'm suggesting that, of course, there are some situations where some things should be 30%. Some things should be 2%, whatever. But we can't tell you that. The content development people can't write that in. You have to decide what that is. But what you have to be careful about is not to do this category here. And the category here is that a lot of people will see one thing and shoot them right down. And so this one is a good example because we saw the teeth issue there, and that might move people down in the score, but it might not be totally enough. It's when people die, or when or when there's something they want to see and it didn't happen, in terms of a decision or whatever, those sorts of things. So the only message I want to tell you is that you need to find a way to still, and even if this one was worth 70% in your mind, you still have to find a way to consider the others and adjust your score. Now this is probably where we get the most variability and the least amount of buy-in because people just can't transition here because the history has always been good, whoa, sharp safety, see ya, 0, you fail. So now keep in mind, remember I said earlier, what are we, 4, 7, okay, good. So remember I said earlier that you're not passing or failing anybody, you're just contributing to the picture. And this should, if it's bad enough, if that one is, one of your 70% things or whatever, if it's really bad, then it should reduce your procedural skill score a bit. But maybe not to the point of a 1 or a 2, let's say. Now this guy here might take you down to a 2, let's say, because there's lots of things going on, depending how severe the things are in terms of your own weighting, then you might take them down to a 2 or a 1 or whatever, depending on how things go. But you definitely want to consider all the other behaviors, even though there were some really bad ones. You want to consider the other behaviors because, again, your goal is to predict future clinical performance. And the only way you can improve that prediction is if you consider more behaviors. The reason why we have 7 stations is because it's a better predictor than 1. The reason why I want you to consider all behaviors is because it's a better predictor than just 1. So you have to find a way to, and again, this cannot be prescribed. We can't assign weights. We can't tell you how to do that. You have to use your judgment. We want you to consider all of them, but definitely take into consideration those bad ones. So it may be that you can't possibly go to a 4 or beyond a 4 because it's not consistently performed, right? The procedural skill was not the standard, so that's going to move us down. Yep.
So how then, using the global rating scale, do you address the situation where in 3 of your 7 cases intubation was required and all 3 times he broke the teeth in that intubation, but he did a lot of other things well, so your procedural skill score came out as a 4 or a 5 because there was a lot of other things that went on really well, but consistently that same skill was performed poorly through the 3 different
Perfect.
cases.
So in the existing thinking on that, we would need to say, I need to see intubation done properly before I sign this person off. That's not how this system works. This system works to say that we want to predict future clinical performance, not just in that skill, but in procedural skills. Right? That's very uncomfortable for people to, to let somebody go through when we see that. That's been the biggest barrier with the base hospitals, the biggest healthy skepticism, because they don't want to do that. That's not how we've been working for many, many years. We've made sure that people pass this skill before I let them go out there. And the way this system works, and that might be something we have to resolve, but the way this system works is it's to predict future procedural skills. And so it might predict that they do that particular skill badly, and that's something that we have to resolve with ourselves. But it's all about procedural skills in general, not just about one piece of a procedural skill. And that's the hardest pill to swallow, in addition to this critical errors issue. Now, back to your point, Sean, about the intubation. That might be something, if it's an issue for the base hospitals, that might be something we document, and when we look at their scores afterwards, we identify and then deal with. I'm not saying you have to ignore that historical rule. Not at all. I'm just saying that there's a different way of thinking about it. So my position would be that we're interested in predicting future clinical performance, and it's true that situation that Sean brought up is a bit of an issue where if you're seeing this consistently, we have to capture that. But I would argue that that would be probably for most people subconsciously weighted high enough that their scores would drop low enough that they wouldn't get through. They wouldn't meet the cut score. So this piece is the part that the weighting and the critical errors thing is the hardest thing for people to wrap their heads around, as well as this issue of, do I capture every single skill? I mean, the history has been, and correct me if I'm wrong, for most base hospitals, is they want to see every single skill, sign off every single skill, and then off they go. And in the 7 stations, we're not going to capture every single skill. It's just the way it's going to go. And that's a very big transition for this base hospital. But again, I would suggest to you that that person is very unlikely to have only that problem. If they have procedural skill problems, that skill will demonstrate, or that issue will demonstrate itself in multiple ways, not just that way. It would be very unusual to do that, not impossible, but unusual. Does that make sense? So this requires, I'm looking around, there's some skeptical faces, but that's okay. So this requires a bit of a leap of faith until you see it in action. And then you'll see some more. Yeah.
So just so that I purposely was saving that question just to put you on the spot.
Yeah.
So
worked.
But I will admit, so we've done thousands of these now in Eastern Ontario, and I will say that your last statement there, that there will be other issues identified, I would say that is accurate. But we do in Eastern Ontario, we do identify each skill individually for reference later, so we can make sure that, what did cause their procedural skill score to be a 3, because is that a problem that might be an issue for us?
Remember this line here that we drew earlier, and we said this, this is a continuum from, no clinical competence to exceptional clinical competence. And every single person has a true we call it a universe score in the stats world. We'd say everyone has a universe score, true performance ability. Our job is to capture it. If it's there, and I allow one behavior to speak for the rest, then I'm not getting close to there. I might be down here somewhere. Because I've moved the score so far down, it's hard to even recover, right? So I've moved the score so far down that the other stations might move them up, but never so far enough to reach the cut score. So that's why it's so important to consider all behaviors. And again, the whole goal is to capture this true performance ability. And again, to your point that you just raised, is that if they have bad procedural skills, it will come up in a number of ways, and they'll need to fool 7 of you. That's not going to happen. That's very unlikely that they're going to fool 7 people. I can, having looked at the cases, 14 people, 14 people. It's not likely. But this is the piece that threatens the process. If we never talked about critical errors, and that, who hasn't heard that term, right? Critical errors in our context. So if we didn't talk about critical errors and you went there and you saw a critical error, it's likely that you would give a procedural score of 1 if you saw a critical error. And I'm just saying, consider all behaviors. So, and you may find, and again, it's very seldom that you're going to find just one problem. And so you'll see a few other things. If they lack knowledge in that piece, it's, like I said, it's probably spilled somewhere else as well. And keep in mind that the content group decides to some extent what's important, right? When they create their blueprint and they create their cases, they're saying this is what matters, right? And that's the point I was trying to make to the group. This is what matters. So they'll build in the big key ticket items if that's what sits with them the most. Now you could see that if they could probably do a subcutaneous injection, the IM injection is probably not a big leap of faith, assuming they can do that one. But there are some other skills, and so those that are big problems, big concerns for them, they'll build in, and they'll make judgments about that. The egregious error issue is a big one. No one's really, pinned it down totally, but again, it's just about the multiple sampling and considering all behaviors that matters. Did anybody have trouble placing behaviors?
Yes.
Okay.
There's a lot of sound issues, so I couldn't capture.
Sound's a problem. And we're probably going to see the sound issue here come up in the scores as well. So that is a common issue. Where do I place certain behaviors? So for example, is the extubation that was done by somebody else, is that a procedural skill or a decision-making skill? So or both, or whatever. So now I would say, again, to try to get our frame of reference and our performance dimensions consistent, I would say that, again, the procedural skill things, when you're scoring those individuals on that it be about what they do. What they delegate off is a resource utilization thing, and then you go from there. Yeah, and then they assess the effectiveness of it. Now the decision, though, to pull out, right, to stop the attempt and to move on to something else is a decision point that they make and could fit into the decision-making category. Now, some people say, when they hear that, they say, well, so this one could be either resource utilization or decision-making. Should I only put it in one, or can they get dinged twice, basically? And the answer is, it's totally fine to put it in two places, if that's what happens, okay? So don't feel like you have to only consider it in one. It can fit in two areas. I would say that the decision point to extubate is one thing. How that gets done is another thing, So, and whether or not it's assessed or another. So you can consider them in both, totally fine. Don't feel like you have to separate them totally like that. Okay? All right, let's see what happened. Okay, so situation awareness. 1, 2, 2 for situation awareness, 2 for those. 3. Now look at this. 4. 3, 4, 5, 6. 5. 1, 2, 3, 4, 5, 6, 7, 8. 6. 1, 2, 3, 4, 5.
Oh, super lenient.
7. Okay, that's okay.
This is like the Olympics, right, where you throw your high score and your low
That's
score.
right, that's right. Okay,
This is my hardest.
so when something like this happens, which I suspect is going to continue, when something like this happens, we clearly do not have the same frame of reference. Right? That's just what happened, and that's okay. So one of the questions that came up a little while ago while you guys were doing the scoring was to say, should we give time for raters to talk? One of the things that we absolutely do, researcher side doesn't matter, one of the things that we absolutely do and will recommend is that after the first case, so if you watch this the first time, we would compare our scores and then calibrate. Because you need an opportunity to see the first case, because there's stuff people do that are just like you never could possibly think of. And keep in mind that you read a very big case and couldn't digest all of it probably, but when that happens, we need an opportunity to have a conversation. What this demonstrates is that you guys have different frames of reference. Different frames of reference. And drift, rate or drift, yeah. Okay, so let's go to history gathering. 1, 2, 3, history gathering, 3, 4, 2, 4, 6, 7, 5, 1, 2, 3, 4, 5, 6, 7, 8, 6, 1, 2, 3, 4, 5, 6, 7, 7. Okay, so very different views, very different frames of reference, and it's just a matter of deciding which way you're going to go with. Listing that out and having that conversation. That's all it is. Okay, that's the way to treat it, or to treat this disease here. Okay? Okay, let's go patient assessment. 1. 2. Patient assessment 2. No. 3. 1, 2, 3, 4. 4. 1, 2, 3, 4, 5, 6, 7, 8. 5. 1, 2, 3, 4, 5, 6, 7. 6. 1, 2, 3, 4, 5. And 7.
No.
Okay. Okay, so the decision making, those who scored it a 3. Why?
This is a
Sorry, patient assessment. Sorry. On day for me too. So those of you who gave a 3 to patient assessment, why? Yeah.
Well, he didn't really, he kind of asked what was going on, but he didn't do an assessment. Like he didn't ABCs, he didn't go through, he didn't also take the chest till like 5 minutes in. He didn't get down for trauma, he wasn't looking at the pupils, he wasn't examining, he wasn't getting a blood pressure. You know, it was more, anyway.
He didn't even actually touch the patient.
No,
for the first number of
no.
minutes.
Yeah, he did.
He immediately went
Okay.
to the pulse,
Yeah,
checked the pulse, and then he assessed the chest with his hand.
I only scored it a 4, but I could also say that, you know, if you're really looking at a primary and he's going ABC and he has a problem with A,
Shouldn't have gone.
It's not ABC though, it's CAB.
Okay, so again, this is just a frame of reference issue. You can see how diverse our views are on frames of reference, and you can see why it's incredibly important in the cases, and again, to put a little bit of pressure on the case development people, you can see why it's very, very important to spell some of this stuff out in the performance expectations. So if they had said, you know, we don't want any history gather, we don't expect any history gathering, to your point, any history gathering in advance of managing this airway, that should be the priority, all things should come second, then you can score it that way, right? If you want to see more patient assessment to be able to make informed decisions about things, then we can score it that way. The point is we have to have a very similar frame of reference. And this case being much more complex than the others, starts to create this variability in performance expectations. So again, the frame of reference is key. The other thing you're seeing here, I do this type of training, a big group of different healthcare professionals, physicians, nurses, RTs, paramedics, whatever. And what you saw in the previous one was a very a good performance. And it's very easy for us to all agree it's a good performance. When you got variability in performance, middle of the road, maybe less than middle of the road, you know, when you see that kind of thing, you start to get variability. And all the more reason to have that frame of reference piece so strong. Yep.
and I don't think anybody should be that discouraged, because when I actually look at the spread there, it's not that bad. Like there's within one, you have more than half of the people in this room are within 1 point.
Yeah, we have some outliers. For sure. And this is very easy with some some very brief discussion. It's very easy to get us to see things a little closer together. And I'm intentionally picking the outsides to show how far apart they can be and have to be corrected. It's that simple. Decision making. 1, 2. 2, wow. 3. 1, 2, 3, 4, 5, 6. 4. 4. 5. 3, 4. 6. 1, 2, 3, 4, 5. You did 5? 7? Dan? No. Okay, so the people that scored 2? Yep.
Just by going off the brief history he received, he already bought himself a phone call to get some Bicar, to get some Narcan. He focused on the airway. Meanwhile, the primary care crew was ventilating the patient. It was poor air entry in the bases. There was air movement. So he should have been thinking, this is what I need to do. I have my line established. Let's get some vitals. Let's go down that path first. Check the pupils. Pupils are a good indicator, you know, and then make a decision from there. I just think his decision, if he was focused on the airway, he's just focusing on the tube. That's all he was looking at.
Okay. Okay. Let me just because that point just hit a not nerve, just an important point. So I would think about that. Just your last statement about his kind of all over the place. He was, that sort of thing, as more a situation awareness. I would just suggest, I'm not saying that you're wrong about thinking about decision making, but I would start to think about that. If these are indicators that maybe they don't really understand what they're dealing with here. Maybe. I'm just throwing that out there.
Say Constellation received the same score for that.
Yeah. Okay. And those who scored a 6.
I thought right off the bat he recognized that it was an airway problem, dealt with it. Contrary to looking at Narcan or whatever possible things, that may have treated that component of it, but it's still the airway. That was the main issue, and we needed the most focus.
Okay, so very different, again, frames of reference here. So we just have to think about, again, if we're going to give you a frame of reference, we have to follow that frame of reference and go through there. Yeah, go ahead.
So I gave it 2-2, so because I didn't want him to have it all for himself, but I saw it in a different way. Although I realized that he did see that the airway was a problem, I felt that it took him, you know, a long time. Like, yes, he did the simplicities of the OPA and the MPA and the nasal cannula and fine and dandy, but he's getting her to read off that list, and which is fine. I mean, he's double checking, but I felt that it took him a really, really long time. Then when I was always taught when you intubate, you always change something when you intubate a second time. I didn't feel, maybe I couldn't hear that, but I didn't feel like he really changed. He still used bougie or stylet twice. He didn't really do anything differently. So to me, that's not him using critical thinking. Additionally, oh yeah, well, I got to try the King LT because nothing else is going to work. They kind of smashed that into his face. So after smashing it into his face, they said, oh no, not going to work. Now I'm going to consider this. He was considering, his first thing out of his mind was getting the IV. Then he was atropine, like who cares? I get it with the Narcan and the sodium bicarb, totally get that. You should be thinking of that as well. But yes, the airway is of importance, and he's not really focused. He's like, you know what, I'm getting tired of working on the airway. Let's try something else.
Okay.
So he's going down atropine. So I really think...
Very passionate. I like that. I'm passionate. Okay. It's totally fine. So
My 2 sticks. No, I'm just kidding.
just a couple things there. So there were a couple things like the smashing of the King LT, right? That's fine, but that's a procedural skill. Okay? So that you have to put that somewhere. The decision for a King LT is a decision. If he hands that off, that's resource utilization. Whether or not that's appropriate or not is for you to decide. So just a couple things there in terms of placing behaviors in the right buckets. And they can go in more than one bucket, but just making sure that you place them somewhere. And then there were some comments where you made where, you know, I would, I think, I should, I would. And that's totally natural and normal for you to use your performance theory, your understanding of the way the case should unfold, but we have to trust the frame of reference that was given to you, right? Everyone has to work off the same sheet. Just as a teaching point, we just want to make sure that we're all reading the same music. And that's the frame of reference piece. Okay. Okay, so resource utilization. 1? Resource utilization?
I thought we just...
No, we did decision making. Resource utilization. 1? No. 2? 3? 4? 5? 4? 6? Everyone else? Anybody for 7? Okay, 3. Yeah.
So there, Dan.
Okay. Okay, so we can leave that one. Communication. 1? 2? Actually, let me come back to this. So this, again, just demonstrates, compared to that we probably have a similar understanding, and this was done well, right? So it's easy to see that it was done well. And trying to distinguish certain things and how well this aligns with our performance understanding or performance theories makes it easier to score. When things are all over the place, like maybe this was or this was, it makes it a little bit harder and you start to see variability. So again, frame of reference, performance dimension, understanding is what tightens this up. Okay, communication. 1, 2, 3, 4, 5, okay, 3, 6, and 7. Okay, so we'll say there's about 7, and we'll say, I don't know, everyone else. So that's good. Procedural skill. There we go.
In scope of what you're saying. No pun intended.
Yeah, okay, 1. I thought there'd be a couple. 2. Okay, 3, 4, 5, 6. 3. 1, 2, 3, 4, 5, 6. 4. 1, 2, 3, 4, 5, 6, 7, 8. 5. 3. 6. 7.
There was a lot of skills that are listed on the sheet.
Yeah.
That were done by him, but is his oversight on the skills being delegated, does that count towards the skills?
So that would move people to resource utilization, yeah. So were there, let's list out the behaviors that were there. If we can think about procedural skills, what do we see, just from memory? You can group it all into intubation, but you can certainly break that out a bit. right? There was,
How much variables is there between the skill of the rater, PCP versus ACP also?
yeah, that would lead to some of this for sure. I don't know what the PCP ACP split is here, or active inactive. I don't know what that is. Yeah, but it is a different frame of reference, and that's the point. And so again, the way to tighten all this up is through frame of reference. Yeah.
I had trouble with the definitions for each category and each grading. And then as you use the tool more, you begin to be able to narrow it better. Because you know that, so like when you look at a 4 and you read the 4, this guy, he knows he needs to intubate, he gets his stuff ready, although annoying. He does the intubation as he should, except he does terrible with the teeth and he makes 3 attempts and he takes too long, but he's marginal, but he needs to have somebody probably watching over him and he needs some remediation. So as you look over it more and more and become more familiar, you'll become more comfortable.
So, but I do want to highlight the dangers of differences in frames of reference. And that's why that piece has to go along with the scale. You just pick this up and use it, and you're expecting other people to see it the same way. They're not. They will most certainly see things differently. In fact, there's a great paper that came out in the last 12 months or so. It's called Seeing the Same Thing Differently. But basically what they demonstrated is they gave a bunch of raters like you the exact same video, had them score it, and they saw the same thing differently. So that will happen, and so the frame of reference piece helps with that. We have to decide whether or not using that little checklist that he went through is good or bad in advance. Everyone in here has their own performance theory, as was like you just demonstrated yours, and he demonstrated his, and you demonstrated his, and so those schemas came out. And we just need to align those a little bit for the purpose of rating. You don't have to agree in your everyday practice, but for the purpose of rating. Yeah.
No, I was just gonna. You just said it. You don't have to be perfectly agreed, because you do need to have your own individual subjectivity when you do this evaluation. That's a necessity. It's just like you said before, for the reliability, maybe you need more of you doing evaluations in order to wash the error rate away. But you shouldn't eliminate your own subjectivity in the evaluation, because what you know and your own practice and your own observations are important.
So what we saw here, what this demonstrates here, again, along the continuum, if their true level of performance is there, we saw some people up here, we saw some people up here, down here, we saw this. Yeah, down. Some down here. And so, but different, so this might be, for example, the procedural skill. And then we have one for situation, or let's use this one. Communication. That might be their normal, and we were here as an example. So this is your signal, this is your noise, this is your signal, this is your noise. So lots of noise around here, lots of variation around here. These are the ones that we have to go after with frame of reference training. The point is, though, over time, over cases, these things will, and again, remember I said the reliability, the way to control that, or control the amount of error, is divide by n. That's the 7 raters that will eventually give us the picture of procedural skills and so on. But this does have to be controlled a little bit more.
So if we're finding one case where we consistently see this happen, is that then sort of frame or grounds for us to go, that case is not working? Or we need to either throw it out or redo the prep on it or whatever, right?
And we would be able to identify whether or not this type of thing was going on. It would be identified as lots of error in one of these dimensions or one of the cases. And so we could identify that, and in the future we could just eliminate that case totally. We could adjust the case to improve it, just do some revisions to it. Or maybe it's just flat out bad raters. Raters that didn't read the frame of reference and use their own performance theories. Raters that didn't use the rating labels and came up with their own, and then we have to deal with that. So these are all things that we'll address. Yeah. Okay, so I want to make sure that as I wrap this up, that we covered off the things, and you tell me if there's anything here from the objectives that we identified at the beginning of the day, whether or not there's anything that still needs to be captured. So I said that we were going to discuss the basic psychometric principles associated with performance-based assessment, and that's the stuff we talked about in terms of Miller's pyramid, reliability, validity, and that sort of thing. Describe the Ontario-based hospital assessment process. I think everyone knows what they're going into as far as a rater is concerned, hopefully. Discuss global rating scales in the assessment of clinical competence. We talked about the global rating scale and how it should be scored. Discuss the role of the rater and identify strategies aimed at improving rater performance. And you want to do as much calibration as possible. You watch a case, you score it independently, you talk about it. Adjust your thinking. Next case, watch it, score it independently, talk about it, adjust your thinking, and on and on and on. And you may want to move cases to get opportunity to see more frames of reference. One of the things that I just mentioned earlier is that people revealed their schemas or their performance theories about things, about how practice should be. And that is what has to be revealed in advance so that you can talk about those things. And again, the frame of reference one is the schema we want you to adopt. That's the point. If we didn't have that piece, then all these things would just continue on like that and we wouldn't be able to pin it down, right? So you got to make sure that you have a way of pinning it down. That's it. We can score another one if you want, but I think maybe you guys are okay. It's up to you.
Thank you.
Okay?